Thank you all for being here this morning, and welcome to the Missouri Opioid Summit in St. Joseph. Look around you. What a great crowd we have today. My name is Deborah Bradley. I'm the Director of Health for the City of St. Joseph Health Department. And I want to recognize a few of our elected officials here today. We have Ms. Gossage from the office of U.S. Senator Roy Blunt. If you could please stand. Thank you. We have our county commissioners, Ron Hook and Scott Burnham. We also have Megan Stickley from the county, as the county administrator. And we have city council members Joyce Starr and Barbara LaBasse. And our city manager, Bruce Woody. It was also brought to my attention that the resource guide in your packet, in your bags, has some misinformation about the NA and AA meetings. So if you're interested in knowing more information, there's a table of individuals down here in the front that are willing to give you current information. And it has to do with mostly the outlying counties. We pulled that information off the internet, so I just wanted to bring that to your attention. So last month, the president declared the opioid crisis a national public health emergency. The opioid crisis is everywhere. Some communities have seen devastating effects of the crisis, while others may have seen just little impact. Fortunately, we have not had a large number of overdose or deaths due to the opioids, especially compared to the ones that we read about in the newspaper. However, in my opinion, one overdose is too many. As our team began preparing for the program, I heard from people everywhere of how opioids have impacted their lives. My guess is that most everyone in this room has been impacted by opioids one way or another. And we need to do something to keep Northwest Missouri out of the national headlines. But it's going to take all of us working together to combat it. On your table is a blue sheet that's an evaluation form. I ask that you would complete this at the end of the summit or throughout the program. And there's also a place that you can put your name and contact information if you're interested in being a part of a task force going forward. I hope that you will join us. Today is the first step of our future tomorrows. I want to thank the individuals who came to speak with us today, and those who agreed to be a part of the panel. And thank you for being here today. This is truly an issue that deserves our full and undivided attention. And with that, I'd like to introduce a man who has worked in public health for many years. He helped address the opioid crisis while working in public health in North Carolina, and he's brought his expertise and his drive to make a difference in Missouri as the director of the Department of Health and Senior Services. Please join me in welcoming Dr. Randall Williams.
It is a privilege to be back here on campus. The response today doesn't really surprise me. I was here earlier. I went to all 115 counties when I first moved to Missouri back in January, and this was one of the first places I came on a Saturday. I spent all day here. The president of the university met with me one-on-one and took me on a tour of the campus, which was very meaningful to me because my father, who passed away, loved Walter Cronkite. And so I sent that to my mother, who's 88, a picture of me sitting in his desk, and that meant a lot to her. And then I spent a whole day with the healthcare system here and the behavioral healthcare system. On a Saturday, people came out. I think about 15 people took their time to meet with me. And so, again, it's just an exemplar of the spirit and how much you care about each other in this community. Deborah mentioned I was with the president 2 weeks ago in the East Room when he declared this a public health emergency. 7 states were invited because we had helped work with the Surgeon General, Jerome Adams, who's a friend of mine, craft a national response. And so the president asked us to come up, and execute this. And again, that's really the purpose today. If you ask me why we're here, it is to align our federal and state and local resources to an epidemic that the president said is the worst epidemic we've ever had, and Governor Greitens has described as a modern plague, and we think that's true. No matter where I go, Albany, Missouri, or wherever, we think this affects about 1 out of 4 families. And so the other story I would tell you, I was in Nixa, Missouri, teaching 4th graders last week, and I asked them what was the most important thing in life. This is 4th graders, you remember. And one young girl raised her hand and said, it's to be appreciative, how important in life it is to be appreciative. And I thought, gosh, she's figured it out at such a young age, because I believe that to be true. So having said that, I like to tell people we're incredibly thankful to our law enforcement here. I share with them that they and I are the only people in Missouri who can keep you against your will. As state health officer, there are 50 of us in the United States, I can quarantine you. I don't like to do that because my staff gets mad because it's a lot of paperwork and we have to bring it. It's just a real hassle. But just remember, I do have that right. So if you will join me in thanking Deborah and the St. Joseph's Health Department and the county government and the city government and the university and all of you for bringing this together. As I always tell people, you don't do this on a moment's notice. It is a tribute to the goodwill that exhibits among these people. You respect them so much. You're not here because of us. You're here because of the local people that you respect. So if you will just join and stand and thank Deborah and her team and all who made this possible. What Missouri is doing different, because I meet with all the 50 state health officers, I'm on the board of directors of our organization that's been around for 75 years, is that the governor has made every cabinet member and every cabinet agency focus on the opioid crisis. Again, we were in Liberty, Missouri, the governor and I were a couple months ago, and a young woman in recovery said, "Governor, I was slowly waiting to die." And I'll never forget that. I told her that as long as I live, I'll never forget her saying that to the governor and me. And so I'm incredibly thankful for our other cabinet members. It affects labor, it affects Medicaid, it affects foster parents, it affects everybody. So I'd like to ask the fellow cabinet members and deputies to stand if they would as we go around the state where all of us are going because we think it's that important. So if y'all would mind standing, thank you. So I want to show a video real quick, and if I could summarize what we're doing different, it is that this is an integrated, comprehensive program to help those 1 out of 4 families. And so often that's who we're helping. We're helping those loved ones, that mom, that dad, that brother, that sister, that coworker, that partner, whoever that cares so deeply and just doesn't know how to help them. I tell people when I come to these rooms, the number one question I get is, how can I help? You come from all sorts of backgrounds. We need all your skill sets. But we think that going forward, we're going to ask our local health departments to champion in their communities combining these resources. So we will be judged how when we come back 3 months from now and 6 months and meet with each of this is the 7th summit we've done, and they've all been standing room only basically, and we have 2 more, we will come back in 3 to 6 months and follow up to see what we're actually executing. So if we could show the video.
Thank you for recognizing how important this problem is and for stepping forward and joining us, each of us in your own ways, to take action, to do something positive to save lives. Opioids are a modern plague. We're losing 2 people a day here in the state of Missouri. 2 children a day are born here in the state of Missouri suffering from narcotic withdrawal. We have a serious problem here in the state of Missouri. For every 100,000 people, we have 89,000 prescriptions for narcotics. What is going to help us to move forward is if we can connect the tremendous heart and the tremendous passion of people who have seen this crisis, who've been affected by this crisis, and then connect that to positive action in our communities, together we can save lives. We've asked everyone to step forward and find what we can do. And the reason why we've done that is because the only way that we're going to solve this problem in the state of Missouri is if all of us find a way to step forward and do different. You know, my boxing coach used to always say to me and to all the guys who he trained, if you want different, do different. The message was very simple. To all of us who he trained, he'd say, if you want a different result from your life, then you have to take different action. If we want a different result from what's happened with the opioid epidemic here in the state of Missouri, we're going to have to take different action. And I'm proud of the fact that we're doing that. Government has a role to play, but government alone cannot solve this problem. So let's do this together. And if we do it together, we can save lives.
So again, what we're doing different is we are using every cabinet agency, every cabinet director, and we're the only state in the country that I know of that's doing this, and we're trying to bring those resources to bear in the local communities where we think that the solutions will come. Part of that is we think it's incredibly important to be available to you. We have a no wrong door approach in Governor Greitens' cabinet, which is if you call me and ask me about a bridge, and we have 10,000 of them in Missouri, I don't say, well, you got the wrong number. You need. I say, well, yes, I don't do bridges, but I'll call Patrick. He does those, and we'll get you to him and get him back with you. So I want to give you my phone number. I was an obstetrician for a long, long time, so I'm used to getting called a lot. It is 919 413-7791. That's my cell. And I would encourage you to call me. If you have a loved one and things just aren't going well, I'll tell you, most of the time I'm just a triager. I'll call Steve Corsi or Mark Stringer or someone and say, can you help them? But we never want you to feel like there's nobody to turn to. And so we want to do that. Now, I always end this by telling you, if you call me between 9 p.m. and 3:41, who knows why I get up every morning at 3:41? I don't set the alarm, but I get up. I'll ask you two questions. I'll ask you how far apart are your contractions, or if you've broken your bag of waters. But once we get that out of the way, we're happy to help you. So again, can't thank Deborah enough, can't thank our elected officials for being there. I know how busy they are. We thank law enforcement. You know, we get up every day in DHSS. We want to protect health and keep people safe. And so that's what we do. So again, thank you. I look very forward to hearing from people in the local community. I think you'll very much enjoy hearing what our federal and other state partners are doing. So thank you again for coming.
Thank you, Dr. Williams. Hi, I'm Nancy Taylor. I'm the health educator at the City of St. Joseph Health Department, and I want to thank everyone again for attending today. Let's give ourselves a round of applause. We've thanked a lot of people, but just really appreciate you guys coming out today. I'd also like to thank our sponsors. We have had a great partnership in preparing for this summit. First and foremost, the Missouri Department of Health and Senior Services, also Mosaic Life Care, City of St. Joseph, the City of St. Joseph Police Department, Missouri Western State University. They've done a tremendous job helping us get this set up and put on today. Northwest Missouri Medical Reserve Corps, Northwest Health Services. They did a fantastic job printing these programs for us. The Convention and Visitors Bureau, they have these little handy plastic bags with some goodies in there, including your cherry mash, locally made here, if you like those. And then also the, as Deborah mentioned, this resource guide. This is just a initial compilation. We pulled information from websites. So consider this sort of a starting point. My contact information is in there. This is something that as we move forward with addressing the opioid issue that we could make a little bit more comprehensive, more up-to-date and accurate. A couple of housekeeping issues. The restrooms are past the drink station, down the hall and to your left. The drink station will be open. The food will be available until 9:30. And if you haven't already, make sure your cell phones are silenced. We are recording this morning, so you don't want to be the embarrassed one when your phone goes off. Also on your table, there are some note cards. Later in the presentation, we're going to have a panel discussion where you'll have the opportunity to ask questions. If you're a little bit nervous and don't want to ask the question out loud, you can write it on this note card, and we will collect them during the break, and then we will ask them during the panel discussion. So as a public health educator, I've worked with several grants that have addressed addiction issues, mostly tobacco related, but none have examined this subject as intensely as many of you do on a daily basis, and certainly not to the extent that our next speaker has. Dr. Angeline Stanislaus will be presenting the State of Opioids. Dr. Stanislaus is the Chief Medical Director for the Missouri Department of Mental Health Adult Services. In this position, she plays a key role in the implementation of a statewide program through the Targeted Response Grant aimed at prevention of treatment of opioid use disorders. She works closely with other experts in Missouri developing treatment guidelines for opioid use disorders. She is a part of the Opioid Crisis Management Team, which provides trainings to substance use treatment professionals across the state, consults with independent agencies in implementing empirically proven treatment for opioid use disorders, identifies gaps in care, and implements effective strategies to bridge the gap. So please help me to welcome Dr. Angeline Stanislaus.
Good morning. I've been truly honored to be part of departmental health in this initiative to address the opioid crisis. I've been blessed to work with some amazing experts in the field. We have a team of experts who work on the state targeted response. A special shout out to Rachel Winograd and her team who makes this possible, that we're able to go across the state, provide training, and help facilities implement empirically proven treatment methods. So every single person here, I'm confident that everyone here has been impacted in some way or the other, or knows someone who has lost a loved one to opioid overdose. As I was working in the Department of Corrections prior to my current job, I had several coworkers. I specifically remember a mother who had her daughter in college, and she knew she was using opioids and had gone to multiple treatments, relapsed, and continued to use it. And she would say every time the phone rang, she would just have this horrible response. And as a mother, I wondered what it would feel like when my phone goes every single time, to think if that was the phone call calling me that my daughter has overdosed. That had a very strong impact on me. I've seen grandparents becoming parents after losing their adult children to opioid overdose. It has affected everybody. It has touched the lives of people from every strata, inner city, out rural areas, rich, poor, college students. I don't think it has left anyone untouched. So it is a statewide problem that we really need to come together. And as our governor said, you want different, do different. So that's what we are trying to do with some of these solutions. So why do we call it a crisis? If you look at the graph, this is from 2015. It's not even from 2017. The numbers have gone up. We're currently losing more people to opioid overdose deaths than gun violence or car accidents. Car accidents used to be the highest number. The 2017 data shows it's crossed more than 60,000 people who we've lost to drug overdoses. This is again from 2015. The CDC data says that we're losing 91 Americans die from opioid overdoses every single day. And that number has gone up. It is about 136 now, even though the CDC hasn't changed it. There is data coming out that number has gone up and is continuing to rise with every advancing day. The main opioids that are contributing to this overdoses are heroin, the prescription opioid painkillers, and more recently, fentanyl and carfentanil. Fentanyl is about 1,000 times more potent than morphine or heroin, and carfentanil is supposed to be even higher potency than that. So even a small dose of these synthetic opioids, if present in heroin or any other substances, can cause respiratory depression and kill you. So fentanyl was involved. This is from 2017 CDC data. Fentanyl was involved in over half of the opioid deaths in 10 states, and Missouri was one of the 10 states. So if you look at the data, you see the climbing, more than 20,000 people we lost to fentanyl. And last week in Kansas City, when we had the opioid summit, the person in charge of the DEA talked to us, and he said that amount of fentanyl that's coming into the state is becoming more and more, and they are actually getting lots of fentanyl, because it's so potent, you can actually transport in small packages. You don't need as much bulk. It really decreases the bulk of the quantity because you only need a small amount to add to heroin or other substances to increase its potency. In addition to that, we see about 1,000 people a day in our emergency departments after overdoses. And we also know that individuals who come into an emergency department facility after an overdose, they're 6 times more likely to die of an overdose within the next year. So this number, eventually we will lose them gradually to death. So how does Missouri look like compared to the other states? We are really in the middle, but actually moving more towards the higher number of death states. So in Missouri, the total number of opioid-related overdose deaths in 2016 was 908. That is about 35% increase from 2015 to 2016, and this number is going up day by day. We are not even able to keep up with the data. When county officials are calling saying we don't have space in our morgue anymore, that is a serious problem. That's how much people we are losing to opioid overdoses. In Missouri, this is again 2016 data from Department of Health and Senior Services. We lost 1,364 individuals to total drug poisoning deaths. Of those, 908 were from opioid-related deaths, including fentanyl, and 377, 1/3 of those was from heroin. So how does the state look like when it comes to overdose deaths? Definitely the eastern side of the state, the St. Louis City, the St. Louis County, and neighboring counties have shown the highest number of overdose deaths, but it is moving in fairly quickly. There are counties, if you look at the map, there are counties in all parts of the state where we are seeing more opioid overdose deaths. But nevertheless, the St. Louis region has been the most affected at this point, but it is moving. And the reason in the city, St. Louis City, is not because there's more people in St. Louis City who are using and overdosing. It is actually people from the neighboring counties coming into St. Louis City to use the substance, to buy it, use it, and they die, and they overdose and die there. So that is one reason why St. Louis City, if you look at it, has a much higher number of overdose deaths even compared to other counties. So the big question that's often asked is, how did we get here? How did we get here? And we know that substances have resulted in problems, but in 2017, how did we get this quickly, this far, to losing so many of our young people so quickly in our lives? So the story starts with the OxyContin story. See, OxyContin was prescribed as a long-acting opioid medication. In 1995 December, it was approved by FDA for chronic pain management. Purdue Pharma, which produced OxyContin, came up with another method of marketing. Until this point, as physicians, when we trained, we would only use opioid painkillers immediately after surgery for a few days, or somebody who's in intractable pain after cancer, for suffering from cancer, or really you're looking at the risk-benefit analysis where the risk is much lower than the benefit of someone being on opioids. In 1996, this changed. They submitted a little editorial article that just said, opioid pills are not as addictive as they believed to be, and also started marketing, going to doctor saying you should try this for chronic back pain or other sorts of pain. It is underutilized. So there was a lot of marketing, direct marketing going with the physicians at that time. So by that, they destigmatized the prescription of opioid painkillers. Also in 2001, CMS added pain as the fifth vital sign. So by this time, physicians are given the message, you have to keep people pain-free at any cost. And opioids do keep people pain-free, and opioids not only manage physical pain, they manage psychological pain, emotional pain, because the brain areas that are lighted, whether it's physical pain or emotional pain, it is the same region. So pain is pain, whether it's emotional or physical. So pain became one of the core symptoms that doctors started prescribing. To make things worse, also the patient satisfaction questionnaires, survey questionnaires, always have questions related to pain management. And you may see all these faces, where is your pain? The down, the flat face, the smiling face, and patients had to rate them. And I think that contributed to a lot. And when we talk to physicians who work in the ER or in the hospitals, they talk about this over and over again. When our questionnaire has pain in it as one of our satisfaction survey, I don't want to be scored, so I'm put in a difficult spot here. So not only did the doctors start prescribing more pain medications, but the quantity also increased. If you look at in 1999, it was 180 morphine milliequivalents, which increased to more than 600 morphine milliequivalents within 10 years. So we are giving them more easily, we are giving higher doses, we are prescribing longer. So those are all three that have contributed together. So the other question is, if you take it a year, how individuals are getting pain pills over a period of a year. If you look, it's less than a month. Most of them would get from friends or somebody. And this is common where kids, typically teenagers or high school kids or early college kids, they get opioid pills. Typically, they're found in the cabinets of family members who probably took one or two of the pills when they had some tooth extraction or something, and then the rest is left over. So kids know, college kids would tell me that they know how to go in and get these pills out of the pill cabinets. They go to the bathroom, they go to the medicine cabinet, pick it up, and then they share it among themselves. So this kind of behavior occurs if they're using it for less than a month. But as the increase starts going longer, you will actually see the red lines in the slides. It is actually prescription from physicians. By the time it gets to 6 months or longer, it is physicians prescribing, not just one physician, it's actually one or more physicians. So there's a lot more doctor shopping that goes on once you cross the 6-month mark of using it. And also as you go even further longer, after 6-9 month period, you're seeing them buying more off the streets of opioid pills. And this is around the time when they start switching to heroin, because heroin is much, much cheaper than opioid pills. Someone told me that a milligram of OxyContin goes for $1. So 80 milligrams is $80. 30 milligrams is $30. So that's very expensive to buy the OxyContin or those kind of opioid pills on the market, whereas heroin is much, much cheaper. So this is the time when they switch, when it's because of cheaper. Now, this is not the full story. So opioid prescriptions alone they're not the only reason why we have this current epidemic. There are other reasons. One is increased availability of heroin. It is everywhere now, and it's relatively low price compared to what it used to be, and specifically, as I said, it's lower in cost compared to prescription opioids. Also, it has become more pure. In those days, they used to make it more, it used to have, they put in more other substance and a little bit of heroin in it. Now it is more heroin in the product. Even the beans that they sell have more heroin in them. And the amount of, and also there's more heroin coming into the country. So they're seizing more and more heroin in the southwest border and other parts of the state. They're transported different ways. The DEA agent was saying that Usually it used to be 70 highway that went where how heroin was transported. Now it's coming through Springfield. So they're finding different routes, and Springfield, Missouri suddenly has become one of the hotspots also. So there's more coming into the country, into the state also. Now, heroin, people who use heroin don't use heroin by themselves, and that is usually another issue. We have to deal with the other issues that go with heroin. It's used as heroin is a part of a larger substance abuse problem. Most of them use at least 3 other drugs. So people who are addicted to heroin, people who are addicted to alcohol are twice as likely to be addicted to heroin. People who are addicted to cannabis are 3 times more likely to be addicted to heroin, and people who are addicted to cocaine are 15 times more likely to be addicted to heroin, and opioid pills, people addicted to opioid pills are 40 times likely to be addicted to heroin. So this is the link between every substance does matter, everything has a correlation, but look at the pills, 40 times. This is a very strong correlation between using opioid pills and using heroin. We look at the trends of heroin use and overdoses. This is the first line is between 2000 and around 2000 and 2004. It's about 10 years gap between the 2 areas. Use among women have gone up; it's doubled. Use among the younger individuals who are between the ages of 18 and 25 has definitely risen, and we are seeing that in our practices as well, clinical practices in the community, is that younger group of individuals really skyrocketing. Income, it is all the income ranges are affected. I don't believe there's any income range that has not been touched. And also those who have, it's about 60% do not have any insurance, and about 60% have private insurances. So again, it's all strata of the community. Okay, a word on fentanyl, I talked about it. It is it's 100 times more potent than morphine, and carfentanil is about 1,000 times more potent than heroin or than morphine. So that means that a small, tiny dose is enough to produce the same effect. And the reason people die of opioid overdoses is because you have the receptors, the mu receptors or the opioid receptors in the brain that gives the feeling of euphoria or decreases pain. But you also have the respiratory centers also have mu receptors. So when there is more of these respiratory receptors being occupied by these substances, they suppress the respiration, and that's how these individuals die. It's because of the suppression of the respiratory centers. So how is Missouri addressing this crisis? The CDC talks about 3 main ways to respond to the heroin epidemic. One is the prevention, that is preventing people from starting heroin or any opioids. Then the second one is the ones who are already using the substances. We want to make sure we keep them alive and move them towards recovery and having meaningful lives. And the third one is reversing overdoses using naloxone or Narcan. So the first one is a PDMP. Even though we do not have a statewide PDMP, St. Louis County has taken the initiative and started a PDMP, and several of the other counties have joined them. And every day there are more and more counties signing into the St. Louis PDMP. And when I speak to doctors, they do find that useful. Our governor did sign a prescription monitoring program for Missouri, which is a database, actually. It's a database that collects information through a contract with Express Scripts. The other prevention efforts in Missouri, there is a Generation RX program, which was started by the Ohio State University, and I know they have a booth out there. The School of Pharmacy in Ohio started it. They have a booth out there in the common area there. And this is about going into schools and educating children, and this is like starting early before they get into using opioids. The other thing we are working on is also educating doctors so that they do not prescribe as many opioid medications. I do believe doctors want to do the right thing, and it is helping them doing the right thing and understanding the impact of their prescription habits in the community. And doctors have been very responsive. We do have an ECHO program, which is a health program where experts in pain management connect to community physicians and community programs, and they present cases, they can ask questions, there are didactics. This meets about once or twice a month. We also have identified physicians who prescribe the highest amount of opioids, and we contact them. We do contact them and let them know, do you understand that you're prescribing more opioids than your peers? Is there something we can help? We have chronic pain experts, management experts with us as part of this team, who then reach out to these physicians and help them manage that as well. The other things that we're working on prevention is also, we have our physicians, we really want to impact the medical students and residents getting out of training. So implementing more training into our medical schools. We have 7 medical schools in Missouri, and we have so many residency programs, and these are our future doctors and the doctors who are going to be in the community practicing independently. So really enriching their exposure to managing chronic pain and also substance use disorders, specifically opioid use disorders, has also been an intervention that we're working on currently. So how are we reducing the opioid addiction? So we do still have to have the people who are already on opioids from losing their lives and also moving them towards a life of recovery. First and foremost, we are actually increasing the access to the empirically supported treatment, which is medication-assisted treatment. We currently have 3 medications that is FDA approved for opioid use disorders, which is buprenorphine, otherwise also known as Suboxone, a combination of buprenorphine and naloxone. Another medicine is methadone and naltrexone. Previously, these medications, when we looked at our agencies across the state, or treatment programs across the state, we found that they're very underutilized in treatment. The main focus of treatment has been group therapies with little focus on medications, and now we are trying to at least be able to offer medications to as many patients as an option for treatment when they go into treatment programs. So we are really working with our agencies being able to offer this medication, especially buprenorphine. Also looking at psychosocial treatments that are more proven to promote recovery. Is implementing really meaningful programs such as craving management, how to manage environmental cues, how to prevent risks that are related to relapse. So much more focused psychosocial treatments. We are also using the support of peer support services, which is important to help individuals when they're hopeless to understand, I will show you the steps you have to take to follow me to recovery. And I think this peer support services has been so underutilized, and now we are using them more, and we are seeing some success using peer support services. The other one we are working on is recovery housing and community centers. During our Kansas City Opioid Summit, we had a parent talk about the importance of recovery communities and recovery housing to really help people once they're out of that acute phase in looking at recovery and finding meaning in their lives again. So SAMHSA did have the state-targeted opioid grant, which is a $10 million grant for 2 years, and Missouri received the grant. We received it this summer. 76% of that grant is to be towards recovery efforts and treatment. So what we have found is that there's a lot of support for maintenance treatment with medication. So far, when any medication was used, it was like medication was used in the early phase of it, like a detoxification or acute model of treatment, and then they're off the medications and only manage on psychosocial treatment. What the research shows is people tend to relapse more on that model, the acute treatment model. We are moving more towards a chronic treatment model, as seeing opioid use disorders as a chronic disease model. The brains have been changed from use of this substance over and over again. So that means you need to manage it like a chronic disease model and help the brain recover slowly over a long period of time. We know that recovery is a multiple-year process, and people may need whatever help they need during that period of recovery, and medications have been shown to help them towards recovery. So medications show they manage the withdrawal symptoms, they decrease craving, they improve retention and treatment, and decrease use of illicit opioids, and hence decrease overall mortality and morbidity from opioids. So what we've identified also that we've seen some gaps and barriers that we are addressing. We are identifying the gaps, we're identifying the barriers, and that is what our opioid crisis management team, as part of the state targeted response, we are working on. One of the things we really found was that there is a shortage of DATA 2000 waivered physicians and nurse practitioners. In order to prescribe Suboxone or buprenorphine, physicians have to go through a 8-hour specialized training and get a special DA number, an X number. And nurse practitioners have to go through a 24-hour training and get and have special licensing. So we are trying to recruit doctors. Doctors, one, they don't feel, there's a lot of, they were not trained in it to start with, so there's a little bit of reluctance for physician to do it. And also connecting the physicians who already have this DAA number, and they're able to prescribe with patients in the community or clients in the community who need it. So we're working on that. We've also found a lot more fragmentation of care of opioid use disorders. Medical is different, psychiatric is different, and then psychosocial is different. So we're actually kind of having a much more integrated care of where the patients can receive the medical treatment, the psychosocial treatment, the psychiatric treatment, all in one place also definitely will help them. And also there are so many dots we see across the state, and one of our jobs is connecting the dots and developing new ones when we don't have the dots. So treating centers, finding treatment centers, making them talk to each other, and helping them implement more empirical models of treatment, and letting the community know that these resources exist for them. And that is important too. You can have the best treatment program, but if the mother of the child doesn't know about it, or the spouse doesn't know about it, what good is it? So we are really, the community outreach has also been a big part of it. The other thing we're really working on is typically when an individual has an overdose and they call 911, the EMT comes in, they give the naloxone or Narcan, revive them, take them to the ER. The patient is there for a couple of hours or 3 hours, and somebody might say, here, you can go for treatment here, and they send them out of the door. We're actually trying to work with more case management after an individual, because those are the really highest risk individuals after they come to the ER of an overdose, and connecting them to resources, using more case management specialists and ways of and doing a warm handover to treatment programs rather than just say, goodbye, go have treatment. The other thing we have worked is we talked a little bit about the ECHO project, which is telehealth of experts who are actually through telehealth connecting to the community providers, thereby giving them the support that they need to implement services that are empirically proven. A little bit about the opioid overdose and reversal with naloxone. I mean, naloxone and Narcan is really very crucial in preventing death. And naloxone and Narcan, naloxone is the generic name for it, Narcan is the trade name for it, and people ask what's the difference between naloxone and Narcan. And by giving this Narcan or naloxone, it actually pulls the opioid out of those receptors that are the respiratory center receptors and from the brain receptors. They just pull it out from the brain, and thereby they waken them up so they can start breathing again. So it is it has been extremely useful, and parents or spouses or friends who have naloxone with them feel empowered to at least help them if they find them blue and not breathing. So it has been very critical, and it's important. Somebody actually said, an naloxone can make a difference of the individual going to the morgue or a hospital. I think that's a very powerful statement, and that's how much the naloxone can impact. And the other issue, we've also found that 80% of heroin users inject with a friend, which is weird because 80% of overdose victims found by paramedics are all alone. So people who use heroin and opioids do tend to use it together as a group. But if one person starts going and stops breathing, they run. The reason is they are either on some kind of supervision. They may be on parole, probation, they've been in trouble. They don't want to get into trouble again. They leave. And this particular, it really impacted me, was I was working in a juvenile facility in Missouri, and one of the girls came in and she was crying terribly. And I asked her what happened. She said that she was using heroin with a group of friends. This was a little rural community with a group of friends, and one of their friends started, it was in the back of a truck. They actually were doing it in the back of the truck. And one of the friends stopped breathing and knew what was going on. And everybody in that group, these are all talking about 16, 17, 18-year-olds, with some kind of supervision. They were on some kind of trouble already. And they all said, we don't want to go back, and I know what will happen if my probation officer comes about it or my juvenile officer comes to know about it. They actually kicked the person to the curb and then took off. And she could not come in terms with it, but she didn't know whether the person was alive or dead. So this will prevent that kind of Samaritan, the law that you're protected. And I've seen videos where they put the person in and then come to the ER and push the wheelchair into the ER and run. And we should, no person should be in that position. Help a life, I think it makes a big impact. And I think this law that we've implemented now will really protect individuals, no matter what their legal circumstances, in keeping a person alive. There are 3 naloxone initiatives in Missouri. The More Hope project is a community outreach program where individuals train in communities and show how to use naloxone. Typically, I think I should have brought a picture. It's the nasal. I think you just inject in one nasal, wait for a little bit, and then if they don't revive, do the second dose in the second nasal. With fentanyl, what I'm hearing is that people may need more than 1 dose. Sometimes they need 2 or 3 of them because of it's so potent. But nevertheless, it will reverse the effect of the opioid. You may have to do a higher dose. The other one is, so we have a More Hope project, individuals, it's another grant through which we are doing community outreach, and anybody needs training in naloxone, reach out to us. We'll send somebody. Doesn't matter which part of the state you are, we will send somebody out there to train individuals. And we are doing it in our treatment centers now. Everybody who's in the treatment center, all the staff are trained in this. So if you go to any treatment center, they would be able to train the family members to use naloxone. The other one is More Heroes, which is a project looking at the criminal justice system. Individuals who are released from jails or prisons or within the first 30 days are the highest risk of overdosing and dying, because while they've been locked up, their tolerance to opioid goes down quite significantly, and they go back and start using it at the dosage they left off, and that is too much for their respiratory centers, and they die. So we are giving a lot more of the naloxone to the individuals who are leaving the county jails, and educating them how to use it. Because they cannot use it on themselves, but they know of another friend or another person who's getting released who could use it on. The other one is the community pharmacy initiatives. Dr. Randall Williams has been kind enough to give a standing order for naloxone, so anybody in the community can walk into a pharmacy and get a naloxone prescription without a prescription. They have to pay for it. Insurances cover for it, but you can just walk in and pick up a pharmacy. Anybody can do it in Missouri, and I think that's a great initiative. So in summary, opioid use disorders and opioid-related deaths are on the rise across United States and in Missouri. What the efforts we have are, one is prevention of opioid use. One of the things I forgot to say in the prevention is drug take back. We are indicating that individuals to safely dispose of their opioid prescription medications after they need. We have some pouches in each one's table for degradation purposes of these medications, but also the counties typically arrange or organize unused medication take back days, and they have been very useful as well. And also improving access to treatment for current opioid users by implementing empirically proven methods of treatment for opioid use disorders. Of all the substance use disorders, opioid use disorders have actually proven to have medical treatment, and they are very effective medical treatment. And prevention of overdose deaths through naloxone distribution. Thank you very much.
Thank you, Dr. Stanislaus. Next, we have Larry J. Revis Jr., Assistant Special Agent in charge with the Drug Enforcement Agency. Mr. Revis arrived in St. Louis in September of 2014. He supervises the staff of 80 enforcement and support personnel throughout the St. Louis Division, which serves Missouri, Kansas, Nebraska, Iowa, South Dakota, and the southern third of Illinois. ASAC Revis also oversees the daily administrative functions at the St. Louis office, which includes Administrative Support Unit, the Special Support Unit, Technical Operations Group, and the Asset Removal Group. Mr. Revis joined the DEA in 1992 and was assigned to the Miami, Florida Division following graduation from the DEA Academy. He has also been assigned to Charlotte, North Carolina Regional Enforcement Team, the West Palm Beach, Florida Resident Office, and DEA Headquarters. During Mr. Revis's tenure at HQ, he worked in the Office of Professional Responsibility as well as the Executive Assistant to the DEA's Chief Counsel. So please help me welcome Dr. Larry Revis, or Mr. Larry Revis, sorry.
Thank you, Nancy. Not doctor, but that's okay. I'll take it. And thank you, Deborah, for inviting me today. I know it's a couple of days late, but I'd like to ask all of our veterans to stand. Thank you for your service. Veterans are twice as likely as non-veterans to die from accidental overdoses of highly addictive painkillers. Since March, 68,000 veterans have been treated in the VA system to help address the opioid crisis, which is good news. But this is really what caught my attention. In Vietnam, Iraq, and Afghanistan, we lost about 65,000 Americans. Last year in the United States, we lost about 64,000 Americans to drug overdoses. I know that's not comparing apples to apples, but when you look at those numbers that are almost equal, we've got a real problem on our hands. And what's that's caused me to do as a law enforcement professional is look at myself in the mirror and admit that I haven't done enough in the prevention and treatment arena of this problem. And it's easy for me to say that's because I'm busy all the time in law enforcement. It's hard enforcing the laws. It's 24 hours a day, it's nonstop. Ask any trooper, deputy sheriff, police officer, or first responder. It's 24 hours a day. But that's not good enough for me anymore. And that's why I'm here. And I am very honored to be invited and to be part of this community. I've only lived in St. Louis now for 3 years, but East Coast, born and raised, most of my career on the East Coast, but I call St. Louis home now. And Missouri's my home state, and I care. And what that means for me is very simply just conversations. Whenever and wherever you can have them. Starts in your family, in the schools, PTAs, soccer teams, churches, synagogues. Just be honest. Have conversations, and let's all admit we got a problem. And figure out what we can do better. Thank you. But what I'm here to talk about today is the supply. What's the state of supply of illegal drugs in Missouri? And the supply is driven simply by the demand. We've got a significant demand in the state of Missouri. So, short note about DEA. DEA has 21 field divisions across the United States. St. Louis is our field division. We cover a very large geographic area, so all of Missouri, Kansas, Iowa, Nebraska, South Dakota, and southern Illinois. That's a large geographic area. And fortunately, we work very well with our state and local counterparts across this area, and that's the only way we can do our job, by those partnerships. And we're very grateful to have those partnerships across the state of Missouri. So methamphetamine continues to be the biggest problem in Missouri. Hasn't changed much over the years. But as we just heard with the prescription opioid crisis, heroin has made a huge rebound, is now becoming almost as available as methamphetamine. And now the heroin is switched to fentanyl, as we'll talk about. In our part of the state in St. Louis, it's a nightmare. The heroin and fentanyl is an absolute nightmare, but it's coming west. I'm happy to hear this not nearly as bad on this part of the state as it is in St. Louis, but we need to be aware. As we already heard from the good doctor, she covered a lot of my topics, so I can kind of skip through those pretty quickly. But in the St. Louis metropolitan area, when I say that, I mean St. Louis City, St. Louis County, St. Charles County, Jefferson County, and Lincoln County. The deaths doubled in 2016. So what we're seeing now is the fentanyl is replacing the heroin market. And as we heard, fentanyl is sometimes said to be 100 times more potent than morphine. It's unfortunate that most of the user community are now asking for it. Instead of the heroin, they're asking for fentanyl. We've heard people say they'd rather be sick on heroin withdrawals and take more heroin instead of waiting for the fentanyl. They'd rather be sick and wait on the fentanyl. The fentanyl crisis has, as we've already heard, has increased the deaths by 300% in the St. Louis metropolitan area. We had over 600 deaths in 2016. You heard a little bit about carfentanil. That's an elephant tranquilizer. Thank goodness we haven't seen much of that. In April, St. Charles County lab did have a sample come in that they tested. But this photograph shows you the carfentanil is the big pill. If you were to put it side by side, fentanyl being the white and yellow, and then heroin being the blue and white. Just shows you how much stronger by graphics that carfentanil is. So one of the issues we have in law enforcement is we're getting better, but when fentanyl first hit us, we didn't really know what we were dealing with. What that means is we would seize drugs and not really know what it was. Sometimes people won't tell you what it is. Sometimes they don't know. So early on, a lot of the lab submissions were submitted under other drugs like cocaine or methamphetamine, when in fact they were fentanyl. We had one individual, as you see here, took 12 doses of Narcan to revive. So not just 3 or 4, but 12. This graph just shows you in 2016, the red is the deaths attributed to fentanyl. So more than 50% of the opioid overdoses in the St. Louis metropolitan region. This may be a little hard to see, but this just gives you a snapshot of significant seizures. The bigger the red dot, the bigger the seizures of fentanyl that we've seen in Missouri. Let me flip it to this slide. So this just shows you on the interstate system, Kansas City I-70, down into St. Louis I-70, Cape Girardeau I-55. The doctor mentioned Springfield I-44 is a huge trafficking route now. And this just represents the southwest border. The bulk fentanyl and heroin that we see in Missouri is coming from Mexico, coming from the drug cartels, no doubt about it. In a minute, I'll talk about a variation, but the bulk quantities are coming right across the border, right up into our state and through our state. Just to give you a few examples of what's been seized by law enforcement, April, 27 kilograms of fentanyl in St. Louis. That was destined for St. Louis. That was not going anywhere else. Kansas City, several seizures that were transiting the Kansas City area. May 8th, 8 pounds destined for New York. May 12th, 14 pounds that was destined for Kansas City. And then May 25th, 60 pounds, which was about 27 kilograms, was seized. That was destined, I think, for Pennsylvania. This is the variation I discussed a second ago. This was in May in Cape Girardeau. We had an investigation of an individual who was utilizing what's called the dark web. This individual was living with his mother. He had bought his pill presses from Canada and China, his fentanyl and other drugs from China, and he was pressing these pills himself in his mother's basement. He had shipped over 10,000 packages across the United States. When we arrested him, you see the top picture looks like a toolbox. Those are all pills that he had meticulously placed in the different sections, each representing a different combination of drugs. When we arrested him, he had 30,000 pills. Any kind of drug you could think of, he had. And you may have heard on the news of a substance called Gray Death. He had that. That was fentanyl mixed with what's called pink, which is a synthetic heroin. So just be aware, especially if you have children, of what's called the dark web. That basically allows people to transact anything they want, especially narcotics, in the dark, basically. You don't transact money, you use bitcoins. So I encourage everyone to read up on that and be aware. Now, this is just a couple of photos from Cape Girardeau of other narcotics, but just to show you the significance of the I-55 corridor and what comes through southeast Missouri. It's cocaine, crack cocaine, and marijuana. Butler County, Poplar Bluff area. I want to draw your attention to the picture on the top left. You see the package that has the blue material. That's methamphetamine. And I want to talk about that for a second because the person who was selling this had dyed that blue for a reason. And I think it's pretty obvious because he wanted to market his drugs to kids by the color. So we see that commonly. Down the bottom right is just some street-level packaging of heroin. Top right is a bulk seizure, I think, on I-60 or Highway 60, southeast Missouri. 18 pounds of methamphetamine, over 100 pounds of marijuana coming out of one car. 2 weeks ago, out of Sykeston, a car that was coming up I-55 going to Indiana, two more kilos of fentanyl. We are seeing bulk fentanyl much more than bulk heroin now. September in Bond County, Illinois, 30 kilograms of fentanyl had come through Missouri, was destined for Philadelphia. That's the largest seizure in the United States so far. So just to give you a visual, when you saw all those bulk packages of fentanyl, so that you can see the equivalent dosage. So you've got heroin on the far left with just some milligrams. You got fentanyl in the middle, which is, probably a dozen specks. And you got carfentanil, which is one spec. So when you look at that photo of the fentanyl in the middle, that dosage could kill somebody. And think of those bulk packages that we've been seizing if they were to make it onto the streets. It's scary. Some photos of some weapons in St. Louis that we've seized. I think everybody knows St. Louis has got a serious problem with violence. We're seeing guns and drugs all the time. Unfortunately, Kansas City and Springfield are up there too. Ranked very high in crime, FBI crime index. We are encountering more and more juveniles in St. Louis. They're involved in the drug trade. And it's very difficult to deal with juveniles for us on the federal system because it takes a special waiver to prosecute a juvenile. So that only happens in very extreme, rare circumstances. But I just tell you that the kids are into things nowadays that I just shake my head and just we do the best we can. But the drug trade in in St. Louis is basically controlled by neighborhood gangs. They're not big gangs like national you hear about. They're pretty much street corner gangs. St. Louis City has had 188 homicides, 2015, 2016. This year, I think they're up to about 170. Young men killing each other. So at DEA, we finally came to our senses and realized there's no way we can arrest our way out of this. There's no way we can put enough people in jail. So about 3 years ago, we stepped up our efforts and developed what's known as the 360 strategy, and that's just a holistic approach to the problem. We have the law enforcement, of course. The other two prongs are community outreach and then engaging with our medical professionals. So we realize that's the only way that we can make a dent in this. It's going to take all three areas working together, not just law enforcement. So just to highlight what the doctor mentioned right here. Just a couple weeks ago, we had the national take back. How many of you dropped off prescription medication a couple weeks ago for take back? Thank you. We collected the largest amount ever, over 900,000 pounds. So we're really proud of that event. It happens twice a year. It gives everyone a chance to dispose of their prescription medications before they become subject to maybe a loved one stealing them. We just encourage everybody to get rid of your unused medication. That's really all I have. It's been a privilege to be here with you. I know it's been a lot of kind of bad news on the supply side. But I want to leave you with a message, and that is, as bad as it is, it can get better. And I truly believe now in my 25 years of law enforcement that it takes prevention. It takes every effort that we put into law enforcement to put it into prevention also. So please join me in being a part of prevention. Thank you.
Thank you, Mr. Revis. So as we get ready for our next speaker, remember to be thinking of questions or comments for the panel that's coming up after the break. They're on those little note cards. So again, if you don't want to stand up and ask the question yourself, write it on the note card and we'll collect those. Also on the table is the blue evaluation form, so please make sure you fill that out so we can get feedback on how well we did for the summit. Next on the agenda is Mr. Howard Westman. Howard is the Executive Director of the National Council on Alcoholism and Drug Abuse out of St. Louis. They coordinate youth leadership, community-based and school-based programs to reduce or prevent the harms of alcohol and drugs through education, intervention, and advocacy. So please help me welcome Mr. Howard Westman.
Morning. Thanks for having me. And Jay, thanks for the pep talk. Dr. Stanislaus talked about prevention in her presentation a little bit, and I'm going to talk about prevention. I'm going to talk about a different kind of prevention. If you think of drug addiction as a cliff, you can put an ambulance down in the valley, or you can put a fence around the cliff. And I bring that up because a few weeks ago, one of my staff members gave me this poem. And I'm not a poetry guy. The last poem I read started with, "There once was a man from Nantucket." But if you'll indulge me, I'd like to take a couple of minutes and just read a portion of this poem by Joseph Malins. It's called "The Fence or the Ambulance." "'Twas a dangerous cliff, as they freely confessed, though to walk near its crest was so pleasant. But over its terrible edge there had slipped a duke and full many a peasant. So the people said something would have to be done, but their projects did not all tally. Some said, put a fence around the edge of the cliff. Some, an ambulance down in the valley. But the cry for the ambulance carried the day, for it spread through the neighboring city. A fence may be useful or not, it is true, but each heart became brimful of pity for those who slipped over that dangerous cliff. And the dwellers in highway and alley gave pounds or gave pence not to put up a fence, but an ambulance down in the valley. Then an old sage remarked, "It's a marvel to me that people give far more attention to repairing the harm than to stopping the cause, when they'd much better aim at prevention." "Let us stop it at source, all this mischief," cried he. "Come, neighbors and friends, let us rally. If the cliff we will fence, we might almost dispense with the ambulance down in the valley. Better guide well the young than reclaim them when old, for the voice of true wisdom is calling. To rescue the fallen is good, but 'tis best to prevent other people from falling." Joseph Malins wrote that in 1895. So prevention, it's been on the mind of people for a long time. But is it something not only we believe in, is it something we invest in? And I would argue that we don't. And when I'm talking about prevention, I'm talking about school-based prevention, providing education, intervention with kids as young as kindergarten. Talking about community-based prevention, working with community coalitions, groups of citizens who want to make a difference at the community level. And I'm also talking about targeted prevention, identifying those who are at high risk. But how do you prevent a disease? Well, how do we prevent polio? You prevent polio by inoculating everyone, not just those at high risk, right? So some of you might say, well, that's right, Howard, but there's no Jonas Salk for addiction. There's no vaccine for addiction. And I would say, well, that's true. But there is 35 years of social science literature, of prevention literature, that lets us know what works, that lets us know how to intervene with kids so that, so that we can inoculate them with the protective factors that are going to help insulate them from the risk factors we know they're going to face later in life. These are the same protective factors, the things that build resilience. These are the factors that protect kids not just from unhealthy choices about drugs or alcohol later on down the road. These are the things that protect kids from traumatic events, from the painful experiences that many kids encounter as they grow up. Because really, we don't just have an opioid epidemic, we have a pain epidemic. We have an epidemic of people who don't know how to deal with emotional pain. So I believe it is important to invest in that. Dr. Stanislaw mentioned the STR money. It was a great deal of money, $10 million over 2 years. My organization received $60,000 of that for prevention to deliver Generation RX, which you'll hear about in a minute. In addition to working with kids to insulate them from the risk factors they'll face later, to help them make healthier choices so they won't even get started with alcohol and marijuana, which you heard earlier this morning make it much more likely that they would have an issue with opioids later on down the road. In addition to that, our organization is also engaged in a broader public education campaign. Pardon me. And to that end, we've had a great partnership with the DEA. The DEA 360 initiative has worked with our organization both on drug take-back and really thinking out of the box. They helped provide the funding for us to put 2 commercials on during the local broadcast of the Super Bowl. Now, we've done this for the last 3 years. We have blown our entire advertising budget on the Super Bowl. Now, why do we do that? Why on one night of the year rather than spreading it out over time? And the answer, of course, even if you're not a football fan, you're going to watch the Super Bowl. Why? For the commercials. It's the one night of the year people are watching TV for the commercials. So I'd like to end by showing you one of the 2 commercials that we ran this year. I'd like to thank the DEA again for its support of this type of initiative. I've talked about the cost of prevention. In terms of the return on investment, there's nothing that comes close. Jay said, we're not going to arrest our way out of this problem. The doctor said in so many words, we're really not going to treat our way out of this problem because once addiction takes root, it's terribly, terribly hard to treat. Although treatment is available, recovery is possible, it's just that 9 out of 10 people who need treatment aren't getting it. So if you can't treat your way out of the problem, and you can't arrest your way out of the problem, it seems to me it makes some sense to put a fence around the cliff to prevent the problem from occurring in the first place. So when people say, how can we afford more money, more funds for prevention, I say in terms of the savings of lives, of families, of communities, how can we afford not to? So indulge me for 60 seconds, take a look at.
I believe in the Second Amendment. Guns have been a part of my family forever. Hell, I learned how to shoot when I was 9. Got a .22 rifle, then a 20 gauge. Did the same for our boys and my girl. They respected their guns. They went to the safe every single time. And then to see her on the bathroom floor, it's just... She was 17. Bang, dead, just like that.
Sarah!
I couldn't get the door open.
Sarah!
I kept screaming, Sarah.
Sarah! Sarah, let me in!
Sarah, let me in.
Sarah!
The fire department came. Police. They found this in her hand. I didn't lock it up.
Sarah! 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 Sarah!
If we did that, you can do that. Thanks.
Thank you, Mr. Westman. That was pretty powerful. If you look around the room, you see these banners that say, your future is key, so stay drug-free. And that's part of our local efforts for prevention. The St. Joseph Youth Alliance worked with the area schools. We have elementary, middle, and high school during Red Ribbon Week. We went out and did a sidewalk chalk activity. And then they left the banners there with the schools to have the kids sign as sort of a pledge to be drug-free. So when you get ready for your break, or when we have our break, you might want to walk around and take a look and see some of the efforts of what we are doing for prevention in our schools. And thanks to Youth Alliance for working on prevention in our community. Next, we have Scott Cady. He's the pharmacist in charge at the Chillicothe Family Pharmacy. He's going to talk about the Generation RX program that we've heard about as another way of to have prevention in our community. So please welcome Mr. Cady.
Good morning. As pharmacists, we're usually down here doing this and counting, so if I look down quite a bit, it's just old habit. The Generation RX program is fantastic. I've actually done a presentation to our local high school a few years ago, and it was, it's where it needs to be. It needs to be with the kids. So we're just going to briefly go over the program itself, the educational resources that are available are for anybody. I'm going to specifically highlight the elementary and the teen resources that we have. And I'm also going to kind of explain a little bit how pharmacists and the Missouri Pharmacy Association, we can help lead the way to medication safety education. The mission of Generation RX is a multi-pronged approach. Its mission is to educate people of all ages about the potential dangers of misusing prescription medications and then prevent prescription drug misuse. It works to do this through the drug take-back program, which was mentioned earlier. My pharmacy, we host that also. We generally do that on a Friday afternoon before the National Take-Back Day on a Saturday because we have more traffic that day. And also, prevention education is another arm. The best practices in pain management, physicians get that training. They can also use the resources of a pharmacist to help in that. And then collaborations throughout the community. This is not something that has to be done by a healthcare professional. The Generation RX program was designed by a partnership through the Cardinal Health Foundation, one of the largest wholesalers in the nation, and the Ohio State University College of Pharmacy back in 2009. So we're going to focus on the prevention education component of Generation RX, and we're going to share how the Missouri Pharmacy Association can help bring this prevention education to everybody. The best part is it's free. Okay, most things anymore always have some kind of a cost associated with it. Oh, I can't do this because it costs too much. Oh, I can't afford it. I can't figure out how to get my return on my investment. This is free. This is free for everybody to use. GenerationRx.org is the website. You click on the Take Action page if you want to get the materials to download. They're intended for everybody. They are very simple. This isn't rocket science, guys. It just takes the initiative to go and to do it. They want to be able to impact every state. Over 100 colleges, pharmacies in 40 states. Pharmacists across the state of Missouri are actively doing this. So we don't have an app for it, but we have a toolkit for it. Okay, we have a toolkit for educational resources of every age and audience. You can see there for young kids, teenagers, adults, university level, patients, people in the workplace, elderly adults. This affects every single one of us. It doesn't just go one place. It's everywhere. All the resources, like I say, can be downloaded for free on the generation.rx org website on that Take Action page. They have a complete collection of what you need to either lead the conversation, do a presentation about medication safety. We've developed a facilitator's guide that will kind of lead you through there, include some suggestions on how to do the presentations, on how to do various activities with either small groups, individuals, larger groups, answers to the frequently asked questions, and just how to get started. So you don't have to go and reinvent the wheel. It's already there for you. And they are tailored specific, so if you have elementary school kids, you'll have one specific for them, teenagers, adults, and so on. The presentations are there. We try to make it as easy as possible. For those that do have Spanish-speaking communities, most of those resources are available in Spanish, which is extremely helpful. That seems to be a growing community in our state. So kind of the key messages as far as Generation RX is concerned, we want to make sure that they're only using prescription medications as directed by a healthcare professional, pharmacist, physician, nurses, et cetera. Don't share them. Don't take somebody else's. Actually, recently, I just had a physician call me, or the nurse call me and said that one of my customers, her neighbor was in pain, so she just handed her box of fentanyl patches. I about came unglued and thought, wow, she just admitted to violating a federal law. Good for her. So, keep your medications safe. I have a lot of my customers also that have lock boxes, and they readily tell me, oh, this goes in my lockbox. This goes in my lockbox. I lock this up. I lock this up. And it's sad that we have to do that. But the messages are similar for each of the audiences, whether it's the kids all the way through the adults, the university level, et cetera. The only thing that's really different is the games or activities that you have for the kids. Are you going to have more of those versus more of a presentation style, PowerPoint presentation style you would have for the adults? So here's kind of a picture of some of the resources that are there. Really just kind of small and kind of hard to read. But this is kind of the adult toolkit. This type of information is great to share in civic organizations, faith-based organizations, PTAs, athletic groups, neighborhood associations, health fairs, any other events that you may have around your community. Mentioned earlier, it is for all ages. I think there's a greater opportunity for kids. Obviously, if you can get and educate the kids before it happens, prevention, an ounce of prevention, as the saying goes. In all grades, we talk about medication safety and prescription drug misuse. We're going to highlight the teen and the little kiddos here. The Ohio State University and the Cardinal Health Foundation work very closely with prevention specialists and the educators to include the age-appropriate information in this Generation RX program. Elementary education is just an introductory level about what medications are. Obviously, most of us have medications in the house, whether they be prescription or over-the-counter, how to recognize them, how we, as adults have to, use them properly and display that, demonstrate that, because kids will repeat everything we say and they'll do everything that we do. So if we don't do it right, they're not going to do it right. My daughters, actually I have 4 kids, but my daughters, I take a thyroid medication in the morning, and so they're always like, hey, Dad, can I give that to you? No. Okay, this is not for you. This is for Dad. Okay, you don't get to touch this medication. This is for me. I don't tell them about misuse specifically. I don't use those terms, misuse and abuse. The Generation RX program does not either. That doesn't mean I don't teach them about it. This is not for you. Okay, your brother has a cough, so we give him some medicine for his cough. Kids instantly, they have a cough. Okay, no, just because you instantly have a cough does not mean you get the same thing that they do. For the teens, obviously you're gonna do it at a little bit deeper level, a little bit larger level. So you're gonna focus on what the misuse is. You're actually gonna use those terms, misuse and abuse, specifically misuse. That kind of encompasses all of it. You're gonna talk to them about, what defines misuse, taking more than prescribed, taking it for why it's, purpose other than what it's intended. An example of that would be, let's say you had a dental procedure, probably get a few tablets of Tylenol 3 or hydrocodone product to help with the pain. They found that it makes them tired, makes them go to sleep. A couple weeks later, oh, I can't sleep. Oh, hey, I'll take one of those hydrocodone. Puts me to sleep. It's those kinds of things, those little steps that can potentially start down that road. The other thing too is peer pressure. How do you handle that stressful situation? That facilitator's guide, and those are the things you have to talk with teenagers about so that they understand how to handle that situation with their peers and be able to stand up and say no. It's a very, very difficult thing to do. So various places to use this information. Classrooms, added into the health education class, career day, red ribbon week, poison prevention week. I will let you know if you are going to do this in schools, you must schedule it well in advance. The presentation I did to the high school kids was freshman, sophomore, while the juniors and seniors were taking their ACT. I scheduled that, and they were doing that in the spring. I scheduled that now. If you want to get into schools, their schedule is extremely busy, especially fall. Spring is usually a little bit easier. But other places you can do it are youth-based organizations, faith-based Girl Scouts, athletic teams. I'm also a Boy Scout leader, so I'm probably going to provide an educational deal for the Boy Scouts, again, probably in the spring, a little bit less busy. Community action meetings, or task force areas such as this. So the elementary education resources, as I said, you're going to have a facilitator's guide. It's going to explain to you what it is, how to kind of run the program. Again, not rocket science. It is available for everybody. You're going to have the activities. They're going to spell them out. They're going to teach you how to play the games, teach you how to get the kids involved in the games. They're going to have other supportive handouts, letters you can send home with the parents so that the parents can have it, can try to have that conversation, or to give them courage to try and have that conversation, because it's not an easy conversation to have. And then some visual aids to help you as well there. Just to give you an idea as far as the elementary school goes, this specific part in the middle there about little Cindy taking more medicine than instructed. The kids can understand if it's a good choice or a bad choice. My son, he wasn't allowed on the iPad, and he grabbed the iPad and went and did some Prodigy, which is a math game thing, and I caught him doing it. And I said, well, is that a good choice or a bad choice? Well, I said, but Dad, it's homework, it's Prodigy. I said, but you took it. Is that a good choice or a bad choice? Well, it's kind of a good choice. Well, you're grounded for the next 2 days from it, so is it a good choice or a bad choice? Okay, Dad, maybe it was a bad choice. So the kids understand the good choice and the bad choice at that level. And the thing is, they get to choose. They understand that. That gives them the power to know that they can make a choice. And that's very helpful to do that as they grow up. And on the teen side, this gives you a little bit different perspective as far as how it's written. It does have some standalone activities, which are great. Games that are more appropriate for teens. Everybody Loves Family Feud. It is a great, fun game to play. Little skits. Kids kind of love acting. They are always acting, telling a story. Here they can tell a story about, within a skit base that's set for them. Minute activities. Their attention span is about a minute long. So you get them to do that, get on to something else, But it gets them active and keeps them engaged. And the more they can stay active, the more they can stay engaged, the more they're going to take from it, the better they're going to be. So on the picture on the left, some things aren't to be shared. The kids always love that, especially when they see a picture, talk about underwear. It's a nice embarrassing thing for them. And then you go from there right into the scene as far as what happens. Okay, here's a scenario. Here's John and Susie and Fred. They're all at a party. Coming through here. John does this. Should Susie do that? Fred, what are you going to do? Gives them a chance to, be involved, be in a situation, and may say, you know what? I've been there. I've done that. I may not have made the best choice. And it hits home. I told the high school kids, they were kind of falling asleep, and I told them at one point towards the end, I said, it does impact you. Okay, it impacts all of us. And I told them a story about in high school where I had gone to a party and seen some of my classmates. And it was on a Saturday night. Come Monday morning, I found out that her parents woke up Sunday morning to her hanging in the backyard from a tree. Okay, that got their attention. It is a personal thing. It does happen. But the nice thing is, another resource there is Pharmacist. We're here. We can help. We are the medication safety experts. That's what we're trained to be. Use us. Okay, we're accessible. We talk to our patients on a daily basis about these things, about medication safety. There's not a day goes by I don't counsel my patients. You know, when they get a prescription written for 1 or 2 tablets at a time, hey, try half. Try half a tablet, see how it works. That may be enough to take care of the pain. You don't have to use a full tablet. If if you're still in pain in an hour, take the other half. We're here, pharmacists are across the state, as I mentioned. We're ready to be able to use the Generation RX program. Missouri Pharmacy Association has access to all of us pharmacists across the state to help you, to help anybody else that wants to do these programs. We're able to educate in schools, community organizations, workplace, anywhere there's patients, anywhere we can help. We strongly believe in this program and want to get it out there to everybody so we don't have instances, where the doctor mentioned, getting a phone call. My sister had to text me about her stepson that had died in a car wreck because he and a couple of his buddies were, I think they were drinking, they may have been smoking pot or anything else, and the driver survived. And so part of his community service, instead of jail time, is going around and telling everybody how he has to live with the fact that he killed 2 of his best friends because they were using drugs, alcohol, and driving. So it's been about 2 years. It's real. It's absolutely real. So if you need anything from the Missouri Pharmacy Association, you want to get in touch with a pharmacist in your area if you don't already know one, contact Ron Fitzwater at the association. His email is there. His phone number is there. If you want to get to generationrx.org, download the material. It's a simple little login and gets access to all the information that you possibly need. It's a wonderful program. I encourage anybody and everybody to do it. It's, like I said, it's simple, guys. It's simple. Just take the initiative to do it. Thanks.
So our next speaker is a lifelong resident of St. Joseph who currently has 6 years of recovery from addiction. He is currently employed as a house remodeling maintenance man for a local assisted living company. He sits on the board of directors for a local treatment center. He has been an active member of his home group of a 12-step fellowship and has recently been elected to the public information chair position at an area level of the fellowship. He is also a drug court graduate. He gives back to that program whenever possible. His is a story of addiction and, most important, recovery. So could you please come on up and share your experience and strength and hope?
First off, I want to thank everybody for being here today, and I want to thank Deborah for all the effort that goes on behind the scenes to bring this great opportunity to the community. I'm an addict, that's what I am. But thanks to the fellowship, 12-step program, thanks to drug court and the treatment community, it's not who I am today. You know, the disease of addiction, it's insidious and it creeps in such small increments that we're unaware. I was unaware that it was happening to me. I'm here to share a message today that an addict, any addict, can stop using and lose the desire to use and find a new and better way to live. You know, the therapeutic value of one addict helping another is without parallel, because an addict can best understand the needs of another addict and best help that addict. The ultimate weapon against active addiction is the recovering addict. And I got a whole table full of weapons with me here today. You know, I'll just start off by, I started using when I was 13 years old. I was going to have a beer for every day I was alive on my 13th birthday, July 9th, 1976. And I managed to accomplish that without getting sick, and I thought it was great. I truly thought it was great because all my friends were getting sick in the yard, and I was unaware of the slippery slope I was going down. I was unaware of the self-centered, self-seeking nature of addiction that started that day. What ends up happening is, as an addict, we tend to see things the way we want them to be instead of the way they really are. You know, I needed someone who had got to that place, who thought like I had. I needed a program that had literature written by somebody just like me in order to find a way out. You know, got something I want to read to you here. The inability to stop using, even with the greatest willpower and the most sincere desire, is what we say when we have absolutely no choice. I was using against my own will. That's the definition of being powerless over my addiction. However, we do have a choice when we stop trying to justify our using. What that means is when I stop and I truly examine all the excuses of why I used. And I needed help with that. I needed to be able to see things the way they really were instead of the way I wanted them to be. I needed to expose that way of thinking to me, and it can only happen through somebody who had came through that ahead of me. You know, the disease of addiction is progressive, it's incurable, and it's fatal. It kills people. You know, I had trouble with that in the beginning because I didn't have a disease. You know, but all I got to do is, by that definition, is examine that, because it definitely has progressed from that day when I first started drinking beer. It progressed to waking up in jail 9 different times and blaming everybody else for it. You know, I had all the evidence staring me right in the face, but I couldn't see it. That's what I needed help with. Somebody who had been there and who examined themselves and showed me how to examine myself. Addiction is a physical, mental, and spiritual disease that affects every area of our lives. I just couldn't see that. You know, the physical aspect of the disease is the compulsive use of drugs, the inability to stop using once I've started. The mental aspect of the disease is the obsession or overpowering desire to use even when it's destroying our lives. The spiritual part of the disease is our total self-centeredness. We felt we could stop anytime. I thought I could stop anytime I wanted to, despite all the evidence to the contrary. That's what I needed help with, that evidence. I just couldn't see it. You know, recently my car was parked out in front of my house, my pickup truck. Somebody clipped my mirror. And the mirror was still there, but it was, you know, I could still see myself in it. But it was broken, it was shattered. That's the only way I can describe how I was when I first got to the rooms of recovery, was I was broken, I was shattered, I was defeated. I had to be exposed that I was living in direct conflict with my morals and my values. And the way of thinking that happens is when we use, we minimize the effects of that use, the effects that it has on our family, the effects that it has on the people that surround us that genuinely care about us. You know, I can rationalize that using and justify it by blaming people, places, and things. I can no longer blame people, places, and things for where I ended up. You know, as an addict, I've got several tragic areas of my life that I can draw on from my experience, but I've got some that apply to this arena today. Is I used to doctor shop. I would go from one doctor to the next doctor, and there was nobody keeping track of it. I would exploit that doctor's willingness to help. I would convince them that they were helping me. I would exploit that, and then I would justify it away. It was about what I wanted, when I wanted, as much as I wanted, and it didn't matter who I hurt in the process. I just couldn't see that. I used to carry my medical records around in my vehicle, and I would figure out small towns that first thing you check for is got to have a pharmacy, and then you could just go to the local gas station. Hey, you got a doctor in town? I'm on vacation. And show up with my medical records and, hey man, I just need a little help getting on back to home, or, I'm here on a job, or, all the lies that go along with that. And it just keeps, as the justifying and the minimizing, and then as we use more, the more shattered we become, the more our perception of reality gets distorted. It's like looking through a clouded lens. And the center of my world is getting more, finding more, and using more. I would buy up people's prescriptions. There were people on a fixed income, and I would justify buying up their prescriptions in my head saying, well, they don't have enough money to make ends meet. They don't have enough money to put food on the table. That's how I would justify buying up somebody's prescriptions. And in my case, it was for personal use only, but I can assure you there's somebody out there buying prescriptions that are hitting the streets. What it comes down to, the core of the disease of addiction, that self-centeredness, it's the lies I tell myself about myself to convince myself that what I was doing was okay. There's nothing okay about any of that. Nothing. It says in our literature that jails, institutions, and death is what was waiting for me. Well, I had been to jails, and I had been to institutions, but I still could not see all the evidence that was right in front of me. I was in November 2010, I received my last felony DWI, and I was placed on drug court. And see, the ultimate justification for me was having my name on the bottle. Well, in drug court, they said you can't have narcotics. And I fought that tooth and nail. I fought that. It's got my name on the bottle. It's legal. Even though I was filling the bottle up, buying the prescriptions down the street from some little old lady who couldn't make ends meet. That's my justification. That's the lies I tell myself. That's the voice of the disease of addiction is my own, speaking to me in my own head. What happens is, as an addict, we leave a lot of destruction in our wake. The people we care about that care about us the most are the first ones we push to the side. We minimize, oh, I'm okay, or I would tell myself, well, I worked hard, so I deserve the right to play hard. I wasn't one of those addicts that was ever without a job. I had the house, the boat, the sports car, the company truck, the expense account. And I like to tell you that I lost all those things, but I put using in front of all those things. You know, I didn't want to be an addict, so therefore I was not an addict. Because my version of an addict was the purse snatching homeless guy that lived under the bridge with a needle sticking out of his arm. That was my version of an addict, and I wasn't that guy. Because, see, I could always compare myself to somebody that had it worse. And when I got to that point, I could always find somebody that had it worse than I did. That's the disease of addiction, speaking to me in my own voice, lying to me and convincing me of my own lies. You know, I was in drug court, and there was one of these friends in drug court, one of these friends, right, that had my back. You know, he said, well, if you just take that prescription of yours and you melt it down and shoot it up, you'll be able to pass a UA in 3 hours. Well, now here we are. That's the answer, right? That was the answer in my head. So at the end of my run, I had been using, and I had done everything that I had done for the months previous in drug court to pass these UAs, and I went in and I seen my probation officer, Julie Becerra. I don't know if you're here, but I love you. You saved my life. And I gave her a UA, and I flunked. I had done everything I had done previously, everything exactly the same, and I flunked. And she just looked at me. She said, well, you got two choices. You can go home and get your tighty-whities ready and get ready to go serve your backup, or you can go check yourself into inpatient. She said, if you're going to inpatient, you got 10 minutes to get there, and you got 30 seconds to make your mind up. That was God doing for me what I couldn't do for myself on that day. He used my PO to save my life on that day. That was October 26th of 2011. I haven't used since. I was an inpatient, and we have a program in our fellowship that's known as hospitals and institutions, where we take meetings into places that can't get out and go to regular meetings. And they brought a meeting in that day. And I seen something in those people that I really wanted. And I knew if they could make it, I could make it. But see, if I wanted my life to go a different direction, I had to take some direction from somebody who had been there. They recommended that I do a meeting a day for 90 days. And I started down that journey, because this has been a journey. And somewhere along the way, I had a fundamental shift in my thinking. Because my thinking can't fix my thinking. And one of the first things I realized is I do not have to do this alone. There's a whole world of us out there in recovery. And all they ask is, what's your problem and how we can help? And I had no idea the journey I was on. But I had to be open-minded and just have some willingness and be able to get honest with myself. That's all it took to get this journey started. And it turns out that another shift in my thinking was it wasn't about me and what I wanted any longer. Because I thought I had the right to feel good all the time. Turns out I don't have that right. If I'm supposed to feel joy, I'm supposed to feel joy. If I'm supposed to feel sad, I'm supposed to feel sad. I had to learn to walk through those feelings not by myself. There's a whole world of people in my life today that I can depend on, and they can depend on me. You know, another fundamental shift in my thinking is, I was sitting in the courtroom, finally had 30, 45 days clean. I was sitting in the courtroom, and I finally had this realization that it's no longer us versus them. It's not us sitting back here and the judge and the POs and the treatment counselors up there. It was just us in that room, just like it's just us in this room. You see, the solution doesn't come from one camp over here or one camp over there. The solution's going to come when we figure out that it's just us in this room and what's the problem and how we can help. We have a spiritual principle, and we're supposed to come together in unity. And unity means to put personal desires aside, put personal agendas aside for the betterment of a common goal. And if we can all focus on our similarities, not our differences, in order to do that, because we're a lot more similar in this room than we will ever be different. One similarity we all have is we're all here to help. That's what we're here for. Our diversity is our strength. My sponsor tells me that if I get asked to share my story, you just do it. And I've been doing that, and I've done it in countless places. And this is not the most comfortable place to be, but it's not about me today, right? It's not about being comfortable. It's about getting outside myself, because when I can do that, that's when the personal growth starts to happen, and that's when the growth for everybody else starts to happen. The steps that I've worked, the 12 steps, they expose myself to myself so I can be better to myself, and then I can go out and be better to everybody else. And I need help doing that. The spiritual principles of trust, honesty, hope, faith, willingness, connection. We all have a connection. Selflessness, and unconditional love. That's the greatest spiritual principle that we have. And the best way to show unconditional love is to lift the conditions off of my willingness. I've got to be willing to answer the phone when the Chiefs game's on. That's setting personal desires aside in unity to help another addict or help anybody. It doesn't matter what comes up on my phone, unavailable, restricted. We just answer it, because the life we save might be our own. That's the fundamental shift that is slowly starting to happen some 6 years later. I've got, they seem to be, sometimes there's a cost. Some people want to know what the cost is. And I have to freely stand up here and give away what was freely given to me. That's an honor and a privilege to be able to do that. I want to share with you a little bit of my experience about the cost. I had about 18 months clean, and a friend of mine I've known for 25 years. I've fished with him, chased girls with him, drag race cars with him, and for the last 5 years I worked side by side with him. And see, we're taught we have to distance ourselves from people that are using, and he had continued to use after I got clean. I had about 18 months clean. He comes up on my porch, and he was 3 sheets to the wind, and we can't graft a new idea onto a closed mind, and he had a pretty closed mind at that point. See, the thing to do, the thing to have done would have been to Next day, when he had a little bit of clarity, I should have freely given to him what was freely given to me, but see, I didn't do that. And he sat down in front of a train the following Saturday and let it run over him. Not an easy story to tell. It's not supposed to be easy. That's the only way I can honor his memory. But I don't have to sit on my hands anymore. Because see, right now there's somebody doctor shopping. There's somebody on a fixed income that are selling their prescriptions, and they're hitting our schools because addiction is everywhere. Right now, there's a baby being born addicted through no fault of their own. And not only do those people need our prayers, they need our help, because what's going to matter is what we do when we walk out of here. Right now, there's a suffering addict who's dying, who's never going to hear our message or any other message. So if you know somebody that's struggling with addiction, I got two things that may help. We need to lower our expectations and raise our acceptance level. We lower our expectations and we raise our acceptance level, because they do not need our sympathy, they need our empathy. And that's the unspoken language when we give each other a hug. So just give them a hug. I love you guys. Thanks for letting me share.
Thank you so much for sharing that, Les. It brought tears to me. All right, at this point, we kind of wanted to just recognize the different sectors of the community that we have represented here. So when I ask your different profession or sector, if you could please stand. So if you're in the medical profession, would you please stand? We can kind of recognize the people in the medical pharmacy. All right. Thank you. What about behavioral health? If we have anybody from behavioral mental health, please stand. Okay. Law enforcement and corrections. Please give a hand. Stand, please. What about from the education sector? If you could please, if we have anybody from the education field, please. Faith-based, people from the faith-based community. How about just general concerned citizens, volunteers in our community? If there are any of those, all right. All right, let's everyone give each other another round of applause, and thank you, Les, again. It was great. Okay, now we're getting ready now for our panel discussion. Our moderator is going to be Jen Gentry. She works at the Family Guidance Center as the Community Mental Health Liaison. She works with law enforcement and the behavioral health providers throughout Northwest Missouri. So at this time, the panelists, if you'd like to come forward, and then Jen Gentry, she's going to be your moderator. If you give them a big round of applause.
Good morning. How has your morning been so far? Good. I have the distinct pleasure of serving as the moderator for this amazing panel. To start out, we're just going to do some brief introductions, and if you would, tell us your name and the agency you work for, and then talk a little bit about how opiates affect the work that you do. Chief Canale, you want to start?
Sure. I'm Chief Chris Canale of the St. Joseph Police Department. And, you know, we've heard some great things today, and, you know, you really can't put a cost to how much this taxes our community. Certainly from the law enforcement perspective, you know, the different people that are touched from crimes and things like that come into effect when it comes to sponsoring that. But, you know, the big thing is, and it was said earlier, there's two things I hit on. One is we know we can't arrest our way out of it. And we are always looking for resources, whether it's to refer someone directly to or somebody's family member who's calling us about their family member. And if I could also just put a local touch, they mentioned the drug take-back. I spoke to Captain Colley of the Drug Strike Force. You know, that's in our local area. About 2 weeks ago, we took in over 700 pounds of prescription drugs. And that's a partnership with the Youth Alliance, Buchanan County Drug Strike Force, Sheriff's Department, the Police Department in the county. Ron Hook was out there helping out. And we just can't emphasize with everybody in here, the next time we have one of those, if you contact somebody that you know that has some drugs that could be turned in and disposed of that way, you'll be doing something to help us out and to help everybody out in the community.
I'm Dr. Lindy Andrews, and I am one of the emergency physicians at Mosaic Life Care, as well as the medical director of the Buchanan County EMS. I also serve as the chair of the State Council on Emergency Medical Services. And from our perspective, this issue that we're talking about today is extremely important, because not only do we see it in the people that we help here in the Buchanan County area, but we are seeing it as an important place for us to be involved in statewide also. We have seen an increase in our overdose runs from 2015 to 2016. It was tripled, and this year we'll have November and December stats to put on this, but this year we're running to probably quadruple that number. So we're seeing a bigger and bigger number of people overdosed. The EMS service is committed to help anyone in the community, in the county, or in the region. We have helped several services with Narcan protocols, and will continue to do so, and also with training for Narcan use. We also are participating in extra education for our paramedics and even our EMTs, so that we can help people in the community and the county better. And we are firmly committed to working with law enforcement and with our other medical colleagues in making sure that we're doing the best we can do to take care of our people who are having problems with the opioids right now.
My name is Deputy Daniel Glidden, and I work with the Andrew County Sheriff's Office. I'm assigned to the K-9 unit, which means I have a dog as my partner, man's best friend. My dog's trained to alert on narcotics, and he's trained to criminal apprehension. My dog is my biggest tool when I'm at work. He's trained on the 4 orders of heroin, meth, marijuana, and cocaine, and can also find ecstasy. When I'm at work, I see the opioid epidemic every night. I run across people that are having problems with pills, having problems with heroin. A lot of my stops I make, people want me to search their cars or something like that. My K-9 gives me probable cause to search their car, and that gets me inside that car, which if I didn't have plain view or plain smell, I would not be able to do. So if I get it inside that car, because my dog alerts to it, most of the time I'll find meth, marijuana, something like that, but something that's becoming more common every day is pills. I find more and more painkillers, stuff like that, people on fentanyl patches. It's really affecting my community, and I'm a rural community. About 13,000 people in my community. Last year I had over 80 felony arrests, just me and my dog alone, and I got the Deputy of the Year for the state of Missouri. And I would not be able to do that without my canine partner, because he is a great tool for what I go out and do every night. I work 7 p.m. to 7 a.m., and it's crazy what you'd see in the opioid epidemic is definitely a problem in my community.
My name is Jim McDonald. For those of you that don't know me, I have the privilege of being the commanding officer of the Highway Patrol here in St. Joseph, serving 15 counties in the Northwest Missouri region, Troop H. Statewide, the Highway Patrol has seen an increase in opioid-related issues, and it's every year the statistics are going higher and higher. Obviously, our primary focus is enforcement, which is expected. However, we are also branching out into the education field and trying to educate our younger folks and anyone who's interested in the efforts that we're putting forth in combating the opioid crisis. We are fortunate, and I don't want to minimize the issue here in Northwest Missouri, we are fortunate that we are not under attack like some of the areas of the state are. St. Louis, Kansas City, Springfield areas, they are seeing a tremendous increase in the amount of heroin and opioids that are infiltrating their communities. Here, we don't see the same extent. However, it is a problem. Most of our officers here are seeing an increase in the amount of prescription pills that are out there and available to our young folks, and that is our primary focus here. So thank you for allowing me to be a part of this discussion this morning. Thank you very much.
Hi, I'm James Jura, the medical director of the center. Is it on? Sorry. No, actually, my light's not on, but I'm James Jura, the medical director of the center, psychiatric outpatient indigent care. Opiates are a large part of what we do, both people that come in for treatment, looking for medication assistance or other help just with the addiction, and then the comorbidity. Drugs make you worse, so people come in with anxiety, depression, family strife, whatever it is that leads them in, and a reasonable percentage of the time, a concurrent opiate addiction is playing a large role, and is often actually what you have to treat initially before the other stuff will get better.
My name is Francisco Aleman with Northwest Health. I'm at Southside Clinic. I've been a physician, a new physician, for 3 years. And as many of you know, in medicine, if you're a new physician, you are a magnet for people seeking controlled substances. So I had to learn pretty quickly to handle some what we call difficult patients, and there's other ways to start assessing them and evaluating them and trying to determine what is the best care for them. And there are times they came asking for some pretty high amounts, like, well, first time I seen you, asking for methadone, asking for fentanyl patch, asking for morphine. So that was a steep learning curve as a new physician. But I've been working through quite a few of those patients slowly as I've been becoming more established, and I've been trying to evaluate and reassess them on a constant basis. And we saw a lot of great speakers today, and there's been a lot of statistics thrown out. And the one statistic that I keep in mind is nationwide, every 17 minutes, there's an overdose death. 17 minutes. That was last year. This year's statistics is going to be different. It's going to be a lower number. As physicians, we have decreased the number of prescriptions by 43 million last year, but the opioid fatality is still increasing. So we are a small part of the puzzle, and I am so happy that this group is gathering together because we need multiple facets to be able to tackle this. So.
Absolutely. So the rest of our questions came from you all, so thank you so much for submitting those. The first question is for our healthcare providers. So do you feel as healthcare providers we contributed to the crisis by putting so much emphasis on pain management? By prescribing methadone, Suboxone, et cetera, aren't we just substituting one addiction for another?
Yes and no. Absolutely, without question. We have done an incredibly poor job of managing our own prescribing habits as a profession. Part of that was driven by some JACO requirements. I've been in practice since, out of med school in 1999, and pain management was all the rage in 1999. There was a big push not to focus on worries about addiction, not just from the drug companies, which did push it, Purdue and such, but from our government. And that was a foreseeable outcome that we're seeing now. So I think that we've done an incredibly poor job of balancing addiction versus pain management as a profession. As a provider of Suboxone, I refer to a lot of folks to methadone. It's substitutive therapy. And so, yeah, if we were starting people on methadone who did not have a drug addiction problem, absolutely there'd be a very valid, reasonable criticism. But when you are able to do risk reduction and help someone essentially stabilize, and the goal should be somewhere 3 to 5 years. Okay, the data is really clear. If you try to stop medication-assisted therapy, they've done some studies that stop it after 4 weeks, 94% of people relapse. You go out to 4 months, you drop it down to 92%. You treat out to 3 to 5 years, and your relapse rate when you come off of these things drops to 60% or so. They are opiates. Suboxone is different than methadone. It's a partial agonist instead of a full agonist. But essentially, this is a very intractable chronic disease. And if we can treat someone with a risk reduction, less harmful drug, and increase the chance of them maintaining sobriety when they come off of the drugs after a very sustained period of time, that's all for the good. No one is out there starting methadone or Suboxone on people who are not already addicted to opiates. So we're not just creating or substituting, we are decreasing the negative social outcomes in a pathway to treatment.
I wanted to add just one thing. It seems like at the root of the problem is pain and how we manage pain and how we define pain and evaluate pain. So, when a patient comes to me in this, we use the scale, 1 to 10, where's your pain? 3. It's like, well, are you able to do everything that you usually can? Yes, but I still have pain. I'm not going to treat that. And then there's some patients that come with a scale of 20. They make up their own scales, that's fine. But you have to, it's very difficult to truly assess pain, and imaging can only help you get there, part of the way. So it's a combination of physical exam and imaging, and focus more on function versus pain, which I think we're slowly moving towards improvement of function rather than, okay, you have no pain, but you never get out of bed. That's really not pain management. It's function improvement is what we need to move towards.
Well, seeing it from the emergency department, we see a lot of acute pain, of course, with fractures and other types of injuries. So on the one hand, our patients may need some help for 1 or 2 days for that. But as far as chronic pain, we have really, in the past year, cut down on our represcribing of any opioids for chronic pain. I think the biggest thing that I have done personally is take more time to explain to patients what pain is and how the other things that you can do for pain. So I think that education of our patients when they come into the emergency department is essential, that we tell them the other things, ice packs, hot moist packs. These are simple things to tell them, and to elevate it, no, you can't go back out and do another 18 holes of golf today. You're going to have to let this back spasm or this pain go down. Or no, you've got a broken leg, you can't go to work tomorrow. You need to take care of these things. So I think the basis for managing pain is to start teaching our patients better about pain and helping them with other remedies for pain besides narcotics. So that's one of the approaches that I've taken.
If prevention is the key to combating the opioid crisis, what can be done in the correctional setting that isn't already being done?
That's a good one. I think what I spoke about just a few minutes ago, education is key as far as from a correctional setting. We have to prevent these things before they start. And the better we can educate our young folks and our people that we have influence over, family members, friends, I think the better off we're all going to be.
No, I would say along those same lines, a lot of it's about relationship building. And the better we can build relationships in our schools with our youth in particular, because, the greatest impact we can have right now is on our youth. And also when we can build those relationships with the folks on the street that are having problems, that do have addiction problems, when they feel that they do have a relationship with some of our folks, we have had some successes on that part in working with people and helping them go the right direction. So I think a lot of it's relationships and continuing to put the time into those relationships when we're largely call-driven in some areas of our job.
I understand there's microphones in the audience, so I'm going to give you all an opportunity to ask questions from where you are. Does anybody have a question? Right over here.
I'm just following up on that question. If we had better institutions to take people that we found that were addicted or on the streets with mental illnesses, and we knew how to decrease the stigma and treat them better, do you think that we would see a substantial decrease in the amount of addiction? If we were able to treat them properly for their underlying issues, such as mental illness?
I think that question is best answered by our moderator who works with law enforcement on these issues. Would you like to take a stab at that one?
Oh, my. We know it's such a complex issue, right? That it encompasses so many different things, from social issues to mental health, and oftentimes people are using those substances to treat all of that, right? I certainly think that if we were able to create more resources, it would definitely help. We need to be able to offer resources when people are ready and be able to take them in and address all those multifaceted parts of it, so that it's not that we're just addressing the substance use. So that I think is just the tip of the iceberg. That's what we see, but we're not necessarily seeing all the other stuff that's going on. So that's definitely what we're always working towards.
And let me say, the reason I put that back on Ms. Gentry is she is a strong partner in law enforcement and a catalyst in Northwest Missouri for bringing in crisis intervention teams, bringing in, we had some teams in place, but she's been a huge help in us expanding those teams, improving the training, and that's something that we feel that the community benefits. That benefits mental health issues, which are often intertwined or related to the drug addiction. So that's it's boosting the resources available to us and the knowledge in the street to refer people to where they can get the help.
Thank you. Other questions? Yeah.
Dr. Jura, would you mind educating everyone about why Suboxone is a little bit different in its ability to help folks? You touched on it being a partial agonist, competitive antagonist. Can you explain that kind of in layman's terms for everyone? Why that helps people with addiction, but why it also saves lives?
Okay, so.
Repeat the question briefly.
What's that?
You want to repeat the question briefly?
Oh, okay. He had asked why Suboxone is different, kind of on a chemical basis, why, and use the correct term. It's a partial agonist, antagonist. Okay, so basically, we have neurochemical receptors. We have these two nerves, right? And they talk. And the way they talk is they throw baseballs back and forth to each other, right? And we have these receptors, opiate receptors, mu receptor particularly, and it catches our natural opioids, our endorphins. When you take heroin or Percocet or whatever, it fills up this spot, okay, this spot that catches baseballs, and that turns it on. Now, your brain's really smart, and so once it's turned on all the time, it's like, wait a second, I need to stop listening. I need to turn off, and that's why we get tolerance to addiction. And when you stop or take away your opiates, so you withdraw from heroin, all of a sudden, your body has stopped creating baseballs, okay? And your nerves are really expecting to hear a whole bunch of baseballs. And so it doesn't hear any, it's not listening because it's down-regulated or turned itself off, you get withdrawals and things like that. What methadone does, okay, methadone is a full agonist, and a full agonist basically means you are 100% baseball, okay? You turn on the receptor 100%. It can catch you really well. So what methadone is a full agonist and turns on those receptors, okay? And that's what heroin, Percocet, et cetera, do. They turn it on 100%. A partial agonist is like halfway turns it on, but it fills up this catching mitt, okay, and turns it on like halfway, but it keeps it full. And so if you take other opiates, you have to take an incredibly high dose to displace that halfway turned on half baseball. And that's what a partial agonist does. So Suboxone is actually quite safe. If you take regular opiates, you basically don't feel them unless you get to incredibly high supratherapeutic doses, which we do sometimes, like if someone needs surgery and they're on Suboxone, you actually can displace it, but you have to use incredibly high doses. So people that overdose, and one of the causes of death in substance abuse has to do with using again after you've been clean, because you're at high risk when your body is no longer down-regulated, okay? So someone who's injecting heroin and says, you know, I always inject this much, they get clean for 2 weeks, their brain starts to feel it again, and then they inject the same amount and it kills them. Suboxone stops the effect by filling up that baseball mitt, okay? And so it stops the effect of the opiates and prevents it from turning it on. So it provides a safety factor. And I absolutely treated somebody who was on Suboxone, and because it's very long-acting, it goes away slowly, and I don't know how to exactly, but basically, if you're imagining that you're pouring out a cup, but you're pouring it really slowly, it's going to get half full, then a quarter full, so on and so forth. The effect, you don't feel it helping anymore when it's a quarter full, but it's still blocking a fair amount of your receptors. So people that overdose and would take deadly ones, a quarter of their receptors can't feel the opiates. So it protects, it's protective in that way. It's chemically a better chemical than methadone. Methadone's more widely available, cost, methadone clinics, some other reasons. But chemically, a partial agonist, something that kind of takes this baseball mitt, turns it on halfway, and then fills it so you can't turn it on the full way, is really ideal for opiate addiction. For whatever reason, keeping those receptors full tends to decrease craving. So there's a different medicine that we haven't talked about called Vivitrol, which is naltrexone. It's what we give in a short-acting form, an immediate release that kind of reverses or brings someone out of an overdose and saves their lives. Well, there's a long-acting form that you get once a month. And it blocks and completely blocks those baseball mitts. You just can't feel anything. And what we know is that your cravings actually decrease. It's kind of opposite of what you'd think. You'd think if you can't feel any of your natural opiates, you'd actually crave opiates more, but you don't. You crave them way less. And Suboxone does that in a large part as well, okay? So that when you keep these receptors, take a step back, the reason that heroin is so bad and all drugs intravenously are worse is the ups and downs, okay? When you're shooting a drug, you get this huge rush to your brain, and then this huge crash. The rush, the speed at which your brain feels something coming up, is what gives you that high, okay? And this is true for any substance, not just opiates. When you keep those receptors full, okay, you don't have that rush up or down, and that's what methadone does, is it keeps them full so you don't have this rush up or down. Suboxone keeps them full at like a halfway mark, okay? So if someone's completely naive to opiates, they've never been on them, and they take buprenorphine, they indeed can feel euphoria and high, but it's less, it's attenuated, because you only turn the receptors on halfway. Okay, and the other thing that Suboxone has that's really good is it's conjugated with a form of naltrexone, this complete blocker. And as long as you take it the way you're supposed to, your body doesn't absorb it. You actually just passes through your gut harmlessly and you poop it out. But if you try to adulterate it, you inject it, you try to crush it up and snort it, it releases this blocker and puts someone into terrible withdrawals. Okay, and that's part of the reason that people are better able in an outpatient setting to manage Suboxone. And initially you do have a lot of family support and you don't make someone try to manage it, because that's what drug abuse is an inability to manage and control the use of drugs. But with time, when you and you know, I don't know how many patients, I'm going to guess it's 10, 15%, probably put themselves into really bad withdrawals trying to abuse Suboxone. You only have to put yourself in opiate withdrawals once by injecting this stuff before you're not going to do it again, okay? So they created this medicine that has a pharmacologic profile that is very good for the way that you'd want to treat addiction with an opiate, a partial agonist. And then they added a substance that as long as you do what you're supposed to, it doesn't hurt you, but if you mess with it, it puts you into bad opiate withdrawals. And so we do see better response rates with Suboxone than the just buprenorphine, which is the half of it that doesn't include naltrexone. So the things that make it good are that it's a partial agonist, and that means it's also a partial antagonist. That means that it blocks the stronger opiates because it keeps the baseball mitts full, and if you mess with it, you go into bad withdrawals.
There will be a test. Yes, right here. There's a microphone right there.
And we have treatment. So at this point, we've got to start with where we need to go with people, where we need to go with the human being. Okay, they're done with treatment. What would you suggest at that point, instead of sending them back out into the world to live life? What's your perspective and what's your point of what they should do at that point?
12-step attendance. I mean, it's really clear. The data is really clear. Treatment works when you're in patient treatment. The relapse rate after a 30-day treatment, you look out 8 weeks, and without further follow-up or treatment, without drug courts, which are actually really, really effective. Okay, so we should actually get ourselves in trouble with the law. And seriously, that's what works. Drug court works for people, okay? But without any of that, just treatment, and then you're out, and you're out at 8 weeks, okay? The studies go anywhere from 85 to 96% of people have relapsed, okay? 15% is the best that we show in a study of people that works for. Now, when you follow that up with 12-step attendance or other types of outpatient mandatory treatment, your response rate drops. Even at its best, it's still about 60, 64%. That's the best that we can do, long-term 5-year data, which is abysmal. But if I can go from a 5% chance of success to a 35% chance of success, that's really impressive. And that's the data that is the long-term ongoing treatment. You don't stop treating drug addiction when you get out of treatment.
I could just comment on that further is sometimes we equate, or some people equate drug addiction and that stigma along with crime. There's a lot of people with addiction issues that aren't involved in crime. And as long as we have those stigmas, there's a lot of people that may not come forward to get the treatment that they need. So, you know, I think we need to look real deep inside ourselves as a community. And I don't know what the answer is to erasing that stigma, but I've known people, you know, like I said, it's affected people in all socioeconomic. There's no barriers between who's affected with this. But we do need to make sure that we're not creating false barriers that are keeping people from getting the help that they need.
Very good point.
There was a underlying theme of prevention, and I think most everybody would be in line with that, as myself included. Prevention, prevention, prevention. When I was a kid, didn't turn on the TV without seeing this is your brain on drugs. We don't see that now. And so you've covered medical, law, state health, federal agencies. You haven't offered any ideas for funding, the biggie. And I don't know if everybody's sidestepping that or it's a question for a different panel. But I want to know when we're going to look at this as a whole big pie, not just law and health. Because we got money going into an uncommon character billboard, but the money's been pulled away from St. Mary's Community Center. So let's get our priorities straight. I don't know who that is directed to, or when this is going, I guess, when's this going to change? When's this mentality of other things don't matter, there's a division, we have to pit the sewer against the education to get money for funding in different areas, and nothing has been talked about this. I don't know where this rates on the priority level. Everybody's in a different space and time as far as recognizing, admitting, and denial. Happened to a family, you know, everybody's in a different place. Every community is in a different phase of the cycle. And we're saying, it's happening everywhere. And then we name 3 cities in Missouri. We're saying it's happening everywhere, and we show 50 states in the United States. Is it happening in Canada? Where's everywhere? When you use generalizations like that, you lose everybody right out of the gate. It's not an everywhere, it's a specific. What's happening here is not happening in St. Louis. It's different. How do we take care of this problem, learn from that problem, get ahead of it? Okay, they're further along the curve. They're on down the road. How do we learn? Because that's, unless something drastically changes, where we're headed. So where's the funding? On a follow-up, please, you guys are coming back. Help us out here. Where's the funding? And when do we look at this as a holistic approach, the 360 view that we've seen up there? All of it together, not pieces separately.
To your point, I think that that's exactly why it's so incredible that we have this room full of people from so many different entities coming together to address this issue. That's exactly why you all are here, right? Is Dr. Rick Gowdy still here? He might have taken off. Chris, would you be able to talk a little bit about funding and what we're looking at? There's a microphone. Oh, there's Dr. Gowdy. Surprise! We're talking about funding for resources.
I'll go first, and then I'll hand off to Dr. Gowdy. My name's Christina Hannon. I also work at Family Guidance Center. To get to the funding piece, Missouri is actually pretty fortunate that our state, with the assistance of Department of Mental Health, who Dr. Gaddy's here to represent, and mostly with the advocacy of Senator Roy Blunt, we are participating in something called the CCBHC Demonstration Project, which is Certified Community Behavioral Health Care Centers. This creates an opportunity for community mental health centers to be funded to treat individuals who don't have a reimbursement source and to allow us to be reimbursed cost, just the straight cost of what we provide to people. So one of the main initiatives of the CCBHC is to increase access, and all of the community mental health centers throughout the state have undergone a process to try to promote access to services. To answer the gentleman's question about pitting funding against each other, I think the biggest thing is not that we say, you know, do we fund the St. Mary Center and do we fund a billboard, but going to our city council members at the local level, talking to them about the need and the priority and what we want our community priority to be, and then getting really involved, because most people don't realize that the biggest advocates we have legislatively, and of course our legislators are the individuals who make decisions about resources for our community, the biggest advocates mental health and behavioral health have legislatively are Senator Roy Blunt and then Senator Rob Schaaf, who has gone to bat for the Department of Mental Health every time. So if you haven't reached out to these individuals and talked with them and conveyed the importance of behavioral health to the community and to what we do, I would really encourage you to contact them, because numbers matter. I mean, people like myself, like Jen, we talk to these elected officials routinely. But if all the 350 people who registered for this today contacted all of our elected officials and said, this is a priority, and what are you going to do to help solve this for our community, and how can we get resources, that makes a difference. It's not just the social worker who's going out providing the treatment saying we need the help, but all of you guys. We need all of your help in order to get the resources necessary to fund services in our community.
I also want to mention on your evaluation form at the bottom, you can fill out if you're interested in being a part of a regional task force. So if this is something, you know, obviously we all have a felt a need to come today. But if you want to work on that broader picture, fill out your information at the bottom, and we can help use this as a jumping off point to address the whole picture.
So, yeah, it's on. You can hear me, right? So Ms. Hannon spoke very eloquently about those ideas, because things that start locally have much greater impact. So what you do in this community translates to what happens in Jeff City with our funding stream. And she is right, your local representatives and senators have been very supportive, have a long history of doing that, because I think this is an active community and people understand the importance of those resources. So just, generally about funding, we're never going to have enough money. Demand's always going to exceed capacity. That's just the way it is. So we've got to be smart about the dollars that we have. We've got to use them in appropriate ways. Dr. Stanislaus talked briefly about the state STR Targeted Response Grant. That's a federal grant, part of the 21st Century Cures Act. That gave Missouri $10 million over 2 years to spend on opioid use disorders. Has to be specifically targeted to those with opioid use disorders. Can't be used for any other substance. Has to be targeted to opioid use disorders. Those dollars are being spent on prevention, treatment, and recovery support services. So we try to run the gamut. You'd think that was a lot of money, and we're grateful for it to get that money. But it's surprising how little $10 million a year is when you're trying to tackle this very significant crisis that we're dealing with. So, but we're very happy that we got it. We're doing some transformative things with that. Medication-assisted treatment for all substance use disorders is really important. It's something the department's been pushing for really almost about 10 years now, using this STR grant to really help us get more prescribers trained. That's a real issue, having significant appropriate numbers of prescribers that are able to prescribe the medication. So it's really tough. Workforce issues are a big problem for those of us in the behavioral health field. I'm glad to see a young psychiatrist. Psychiatry is an aging profession.
Not as young as I used to be.
I know. So it's getting really hard to, if you look at the trends for ages of psychiatry, it's getting really scary, because most psychiatrists are on the tail end of their career. So it's a constant struggle, and we're never going to have enough resources, but we have to use what we have wisely and try to target the issues. And Ms. Hannon spoke very well about how important local efforts are to make sure that those who make the funding decisions in Jeff City understand what's important to you in this community.
We have another question over here. So the question is, what gaps do they see in the community right now, and what can we do to address those gaps?
Well, I'll start with, it doesn't seem like there are as many treatment options as we need. That I know of somebody that came to me in confidence. And he felt that the only way he could get treatment was to go down to Kansas City. And we have some great institutions here. The center, can't say enough about the great work that they do and family guidance. But I think we need to make sure that the resources to help people are proportional to what the real problem is. Just to add to that, I think one of the things that we see as law enforcement is when we do take people in for treatment, many times the follow-up does not seem to be there, so they receive that treatment. We're seeing the same folks time after time, sometimes back out in the community in a very short period of time.
what happens after they get there, I don't know. That's not that's not our area of expertise. However, it does seem like that many of the folks are back out on the street in a very, very minimal period of time after being admitted for treatment. What the rules are for keeping them there, I don't know. That would be something for Jen to answer, but I know it is a reoccurring problem.
Dr. Andrews?
From the emergency department side, there's not all the patients that come in needing help, mental help, qualify for overnight or qualify for hospitalization. And Dr. Jarrett can speak to that a little bit more. However, before they leave the emergency department, if they're not going to be kept, they're not only talked to by the mental health liaison, their case gone over by the psychiatrist, but the ER also has care management and social worker resources. And when they leave, we have given them some referral resources and some somewhere to go to get some help. We're not trying to leave them in the lurch. We do give them all that information, but I have to admit there's a gap there, because if you do that on a Friday night, they may not be able to get to any help until Monday. So there's got to be a little more interaction in there, and our care managers will call and check up with them. So we are trying to help these people find some help and to hold them over to bridge that gap until they can get to that help. And I can tell you that my paramedics and EMTs also know a lot of our folks in town personally, because they've transported them a lot, and they sit down and talk with them. They've bought them clothes and gloves and done all sorts of things to try to help them and try to have relationships with them, so that and they know them well enough to know when they're really, really getting badly in trouble. And they also know who their families are, and will call their families to try to get them to get back with their families and things like that. So we all have little pieces and parts that we're trying to do to help bridge over some of these gaps. And this also goes on with your opioid abusers also, and your other folks that our crews have relationships with a lot of them, and try to help them as much as they possibly can. And I'd also like to introduce someone. Deb, I'm taking a little time here, but Dustin, stand up, would you? This is Dr. Dustin Smith, and Dustin was one of our emergency room physicians until he decided he wanted to go to St. Louis, to the dark side of the state, to practice medicine. Had very good reasons for it, but he is very interested in this subject also, and is trying to work with the community on helping also with this situation. And for someone who doesn't live here anymore but has developed a deep relationship with this area, I wish you'd give him a hand, because I think that's terrific.
I came back to Missouri because I'm Missouri made, okay? So one of the things that Dr. Rivas brought up, actually 3 points on her slide. Number one was prevention. So I don't know about you guys, I went into medicine because I like to help people and I like to do things. I have to admit, I really hate meetings, okay? I came here today and I listened to all these topics because they're important, and I know a lot of people here had to be educated today, but we need to leave here today with some action items, okay? Number one, prevention. One of the slides focused on the fact that a large portion of people who are exposed to opiates are from leftover prescriptions, okay? The President's Drug Strike Task Force statement says that pain qualifying satisfaction scores have to go away, okay? Number one, that's an action item. So I think there's only one hospital that represents this community currently. They can either wait until that's a federally mandated statute, or they can come forward and say that we are no longer going to require our physicians to treat to pain scores. If you want to pretend like and let me preface, I have no vendetta with our hospital. I loved every minute that I spent in that emergency department. I treated many people's family members here. But if somebody looks you in the eye and says that, when somebody says, what pain medicine are you going to give me as you're about to leave the room, and you don't think, well, my contract says if I don't satisfy 70% of my patients, I could be fired with cause, that you're not thinking about whether you're going to go home to your family and wonder whether that's a possibility, then you're not being honest with yourself. So, again, I'm not sure one on point, but it's an action item. If somebody wants to work on that, that's something that we can look at. Medication-assisted treatment, one of the second items on the slide. 90% of people who need treatment don't get taken care of. A gentleman over there made a very pointed statement, and what it came to was funding. And I think the response we got was, we've got to use the funding that we have really well. That's not really working so well right now, okay? Because the answer is 90% of the people who don't have funding or who are not getting treatment don't have funding, okay? And so I used to think, well, if they could pay for drugs, they can pay for treatment, right? That's a pretty common statement, right? Think about where they're getting the money. They're stealing it from their family members, and I'm not trying to stigmatize anybody. That's a very important point that you mentioned. Not everybody who is addicted to medications wants to be a criminal or is a criminal, but they find ways of getting money, whether it be lies or cheating or stealing, selling themselves in one way or another. So we have to find ways to not only get people in front of a physician who can prescribe medications that will help, but also helping them to get the medications that they need so this cycle doesn't continue, okay? The third thing, so let's say I have somebody who shows up in my ER. They got a dose of Narcan. We caught them with our safety net, right? We talked about that. We have to save people who are actively addicted. That's great. And they come into the ER, and every one of them are apologetic. They look and they cry and they apologize. And they said, I never wanted this to happen, because they never planned for it to happen. And so we can feel good and we can say, you know, that Dr. Williams has authorized Narcan to be given to everyone in the state. And I tell them, hey, you know, we're going to get you resources. Here's your sheet of paper. If you're one of the 10% who can find resources, or family can get you to Kansas City or somewhere else that you need to be. But if you're one of those 90%, you feel really good about that right then. Yeah, you know what? I hit rock bottom. That's the term we use, right? I hit rock bottom. I'm going to get treatment, or yes, I'll fill that Narcan script. And then they go to the pharmacy. Does anybody know what Narcan costs if you want to buy it? Well, there's some coupons. So usually about $50 to $120. And if you can get heroin for about $10, you know, it may feel like, yeah, I'm going to get on track. But then that craving starts to hit 2-3 hours later. And I know what they're going to buy. Now, their family member, if they've got the money, they might buy that dose of Narcan for them. But what are they going to do after that Narcan's been used if we haven't broken the cycle? So I'm not here to preach. I'm here because I love this community. I'm here because I got tired of going to meetings and tired of hearing about this epidemic. And every day we're reading articles on the news and we're talking about what needs to be done. It's time to do something about it, okay? So I have friends here at this table. I have friends in this community who want to help. There's some people who aren't necessarily on our side. And that's really sad, because they only see that that's those people. Those are the people who were affected. It's all of us. How many people were addicted to the coffee that they drank this morning? I know what happens to my head if I don't have enough. It's about to explode. And that's the same thing that if Starbucks was shut down, well, yeah, I don't have my Starbucks, but I'll go to the gas station and get the coffee that I need. And that's the same thing that happens when we reduce the amount of prescriptions that are written and start yanking people out from underneath of this addictive sort of cycle that we've created, okay? So we have to come up with a solution, not just we'll make all the drugs go away. We saw 73 pictures of people that are more than willing to provide a supply. And it doesn't come in a pill form. It comes from wherever, whether it's China or Mexico or whatever. We're not going to get into all that. But the reality is we reduce the supply. We provide a resource so those people get the rug pulled out from underneath of them. And we support them as a community. So, again, I'm not here to preach. I appreciate everyone's time. Lindy, thank you for giving me the opportunity. Thank you guys for allowing me to be a physician in your community for the last 5 years. I'm still here, and I need other people's help. So it doesn't just take psychiatrists to be able to prescribe Suboxone. Other physicians can become trained as well. It's 2 afternoons. 2 afternoons and a willingness to say, I want to be a part of the solution. So thank you guys for letting me ramble. I appreciate your time.
Anything you want to add?
I could not more strongly agree with the cessation of pain management as a requirement for employment. As psychiatry, that was never something I had to deal with, but it's just one of the worst ideas in human history. It's terrible. As to the original question, we have an okay community for substance abuse treatment. There are huge gaps, and I'll talk about what an ideal situation would look at, but honestly, our law enforcement does a pretty decent job compared to some other communities. The hospital genuinely does try to provide resources. They have care management who will go and get a patient and bring them into my clinic at times. I mean, it's a mid-level, could be better, but really there's a lot of communities that are worse than where we are in treatment. An ideal situation, in my opinion, you make me God of everything, okay? I would do a couple different things. One is that we should have 24-hour available inpatient treatment, right, in our community. And typically that is nowadays for 21 days, sometimes 30 if you got decent insurance. That should be for 90 days, okay, because we know that duration of inpatient treatment is correlated to relapse when you get out of inpatient treatment. Then you transition to a partial hospitalization. Okay, now Family Guidance Center does a pretty good job with 4 hours a night and things like that. True partial hospitalization is 10 hours a day, 5 days a week. And you do that after inpatient treatment. And you transition from partial hospitalization to 3 times a week, and during this time you're involving in 12-step or other outside activities that you can continue once you're out of the system. And you do that for somewhere around 4 to 6 months, and then you transition to outpatient treatment. That's what an actual good system looks like. And you involve an outpatient commitment. Our state does not actively do outpatient commitment. So you talked about bringing someone to the hospital for substance abuse treatment. We don't have substance abuse treatment at our hospital. We have a psychiatric unit. Okay, they are different things. And so our state doesn't follow up with outpatient commitment. Other states do. You can get committed up to a year where you have to go to your outpatient appointments. And if you don't, then you get in trouble. Okay, to be admitted to an inpatient setting, you have to have an imminent risk of dangerousness. And that's why people come in and they do get released. And we're like, why? They were falling down drunk. Well, if they're sitting down drunk, they're not really dangerous. They're disruptive and they're hurting, okay, and they need help. But they're not imminently dangerous. And we just have this balance of where we value civil liberties versus commitment to say you have to be imminently dangerous. Some states have a slightly lower threshold for outpatient treatment. And I believe that would be a good thing that we do as a state law, which says, okay, you go in front of a judge and you get a court order, and it's not like, again, I'm a big fan of drug court. People stop using when the pain of changing is less than the pain of staying the same. And that pain of staying the same usually involves negative consequences from drug use. Okay, so you said not all addicts are criminals, and that is without question. But anybody in here who doesn't think if you get addicted you will do criminal acts is vastly underestimating the power of addiction. Okay, everybody in this room will do that. If you were withdrawing from heroin, you would steal from your mother. Everybody in here would do that. This is an incredibly powerful disease. And so we have to have some sort of negative consequence that pushes people to treatment. And certain states, I did my residency in North Carolina, and they have an outpatient commitment. It's less of a threshold than the inpatient commitment because you're not removing quite as many civil liberties. And you can impose it before people end up in the criminal system because it's a health system, not a criminal system. And yet then if you don't follow through with treatment, you get picked up by the sheriffs. And you do have to ask yourself a question. If I'm willing to go to jail over a weekend versus show up and talk to someone who's going to tell me I have a drug problem for an hour, maybe I have a problem, right? That's the stuff that gets people to change. So outpatient, sorry, I forgot outpatient. Outpatient's not terrible in the community. Again, it's not. There's communities that are worse, but as you go from partial hospitalization, there should be a seamless transition to outpatient providers, okay? Passing a state law for outpatient commitment, not just inpatient commitment, which is what we have now. And again, I can't stress this enough. You bring someone to the hospital because they have a drug problem and they don't admit them to the hospital, that's because we can't adequately and appropriately treat them. We're not helping someone to put them up on a psych unit for 24 hours just because they have a drug problem. It doesn't change anything. And that's why they don't get admitted. Now, when you're acutely suicidal, which happens when you have an opiate problem, because this is terrible, then we admit you for the suicidal ideation. But we're not really geared to treat substance abuse at the hospital here. And that's not really a failing of the hospital, it's just the way the system is set up. We should have an inpatient treatment available in the city. And it's above my pay grade to figure out how that happens, but that would help.
So, unfortunately, we are out of time. One more? Okay.
So I love it when somebody just stands up and just starts throwing down the truth. And so as one of the 4 people that stood up from the faith-based community, I'm going to throw down one more truth, and that the church is not here. And so what I would like to ask you all is, you know, the gentleman that stood up recognizes the fact that God had a hand in removing his addiction. Right? Am I wrong? So this is an emotional thing for me because I want the church in the game. We need to be in the game. There's 4 of us here. Come on, I know there's more Christians here, right? Is there more Christians here who believe that? So I'm going to ask you guys, how big of a deal do you think the fact that the church is not playing a big role in this? And tell me, what can we do to get in the game?
Jump on that.
I don't know about the role, but I will say that you know, a lot of times when I speak to different groups and I speak about law enforcement, really, we're the last-ditch effort to control any type of behavior. Really, the primary institutions of control are family, church, schools, neighborhoods. When those things are strong, you need very little of us. So I will say that the church community, you know, our religious communities are very important to us because they make us a stronger community, and they also help control behavior way more than we can.
All right. Unfortunately, we are out of time. I wish we could be here for much longer. I know you all have a lot of questions. First of all, I want to thank everyone up here for taking the time to be here. And I want to invite Deborah Bradley up here for some closing comments.
Nice to meet you. I heard your name around the community.
Okay, so as we wrap up, please join me in thanking all of our speakers and our panelists today. I also want to again thank our sponsors who are listed on the back page of your program and all the people who helped pull this together. And finally, thank you for being here today. As a reminder, please complete the evaluations and include your contact information so that we can move forward and we know how to get in touch with you for your help. And then now, please, once again, welcome back to the stage Dr. Randall Williams.
Again, on behalf of all of us in the cabinet and the governor, thank you for taking time today and caring enough. It's very important that you understand that for us, it's something we think about every day. And when I heard Les speak, it's something that I'll never forget. And so I want to thank you for that. I think we sometimes forget that if we had breast cancer or some other disease that I took care of for 30 years and got healed, we would tell everybody about it. But often when we recover, we don't go out and tell everybody about it.
And so, Les, that's why I greatly appreciate your share. It takes courage to do that, and I thank you for your courage. It certainly meant a lot to me. Very quickly, the reason we come here is also to listen. I was a physician. The first thing you do when you walk in a room is you ask, how can I help you? That's what you say to a patient. And so that's what we're doing here. We're listening to how we can help you. The governor, the head of the Senate, the head of the Missouri House have all been to these summits and listened. And so just so know going forward, what we're doing is that our first thing is prevention. We know that there are 89,000 prescriptions for every 100,000 Missourians, and that 80% of all the oral narcotics used in the world are used in the United States. So in the 2018 session and going forward, we are doing different initiatives, both policy and budget and legislatively, to work with physicians. We have 20,000 physicians here in Missouri, and nurse practitioners and dentists, to decrease and use CDC best practice guidelines to prescribe for chronic pain and narcotics. We also are trying to push out, we have 20,000 physicians in Missouri, but only 400 are waivered to treat drug addiction. I'm one of them. I will start seeing patients in Springfield in about another month, pregnant women, because I'm an obstetrician, I'm licensed to practice. So I don't have a lot of time to do it, but I think it's really important that we all do our share, so I'll start seeing patients in their prenatal clinic there who are addicted to heroin. But I also want to talk about that the governor and I also believe that faith-based initiatives are incredibly important. I've seen it in my own life. I've seen it in my patients' lives. And so we're incredibly appreciative to the faith-based communities for being involved as well. We also want to save, we never want anybody to die for the lack of a little bottle of nasal spray. So under Missouri law, under my DEA number, anybody can walk into a pharmacy and get Narcan. A 14-year-old can walk in and say, I'm worried about my brother. And I don't want him to die in the next room. And they can get Narcan. So we think that's a great step. And also the Good Samaritan law. We don't want a young high schooler in St. Joseph's to go to a party and let somebody die alone lest they get in trouble. They're not going to get in trouble. We want to save their life. And then the last thing is just treatment. Again, we feel very strongly that we have to increase our treatment options, both inpatient and outpatient. Like I said, we only have 400 psychiatrists in the whole state. So we think the way to do that is to get family practitioners and other primary care doctors throughout Missouri more comfortable using and referring people for this. You know, if you're in Andrew County or these other counties, that's what you have to do. You know, I sit here and I look at law enforcement, and I can just promise you that at some point they've had to go knock on a door and have a parent come to the door and say, I'm so sorry to give you this news, but you've lost your child. And so I know how tough it is because I've had to do it as a physician. Just understand this, that all of our actions, whether we're in Washington advocating or in Jeff City, are all moving toward trying to make that happen. Never again. So thank you. And thank you, Don. Thanks for coming.